Dr. Noor. So please start the live streaming.
Yeah, we did it. We did it 2 minutes before. Yeah.
Okay, so over to Dr. Abhinav.
Yeah. Good morning, everyone. Welcome to day 3 of GIAN Orofacial Pain course. And myself, Dr. Abhinav, I will be coordinating today's session. The theme for today's lectures are diagnosis based on history and examination. So lecture 1, the topic for lecture 1 is TMJ, rheumatoid arthritis and osteoarthritis, manifestation and pathogenesis. Rheumatoid arthritis is a chronic systemic autoimmune inflammatory disorder that is characterized by joint inflammation, erosive properties, and symmetric multiple joint involvement. Systemic weight loss, fever, and fatigue may be the first presentation of rheumatoid arthritis. TMJ is very rare to be affected in the early phase of the disease, thus posing diagnostic challenges for the dentist. On the other hand, osteoarthritis encountered in clinical practice present as a chronic debilitating disease resulting in altered joint structure due to degradation and loss of articular cartilage, along with changes in the subchondral bone and other soft tissues. Degenerative joint disease is a frequent finding in the temporomandibular joint. Consequently, a good understanding of the use of diagnostic algorithm will be lead to a better control of osteoarthritis in TMJ. Dr. Islami Rehma Hutami will now discuss in detail about the TMJ rheumatoid arthritis and osteoarthritis manifestation and pathogenesis. Dr. Islami is a researcher and a scientist at the Department of Orthodontics and Dentofacial Orthopedics, Tokushima University Graduate School of Biomedical Sciences, Japan, and has specialization in orthopedics, osteosarcoma, bone marrow transplant, chondrosarcoma, bone fracture, bone marrow fibroblast, and osteogenic differentiation. Over to Dr. Islami for the presentation.
Okay, thank you. Am I audible? Okay. Am I audible? Okay, thank you for having me on today's lecture. It's a great opportunity to be one of the speakers on the global initiative of academic network that is held by the Aligarh University of Dental Faculty of India. So my name is Islami Rahma Hutami. I'm from Orthodontic Department, Islamic University of Sultan Agung, Indonesia. So as already told by the Dr. Abhinav, that my title for today's lecture is temporomandibular joint, or we can simply call it as TMJ. Both rheumatoid arthritis and also osteoarthritis, the manifestation and the pathogenesis. Well, here TMJ is not TMJ's disorder specifically. It's not only studied by the prosthodontist, orthodontist, or periodontist, but for the general dental practitioner must aware about this disorder. This essential things to get to know about this disorder is we have to aware that this disorder exists. Oftenly in my clinic, I usually found about 8 of 10 of my patient, they have defect on their TMJs without they realize that they have the defect on the TMJ. So it's very interesting to talk about the TMJ. So we have to recognize the characteristic manifestation, and we have to able to detect the sign and symptoms of these disorders. Okay. So this is my research timeline. Since 2011, I start to study about the acute inflammation, and since 2015, I start to study about the TMJ arthritis. I focus on the intracellular signaling pathways such as the sphingosine 1-phosphate and its receptors. And 2017 until now, I still continue to study about TMJ arthritis and also oral mucosal wound healing, the cross-signal interaction between sphingosine 1-phosphate and hypoxia inducible factor. So here is the Indonesia. I live on Java Island in Central Java in the Semarang city. And this is my city, Semarang. So, and this is my faculty, a dental faculty, and this is the hospital, dental hospital. So I graduated from Tokushima University, the place where I met the humble and very brilliant person like Professor Matsuka and also Professor Saista. And we have a very tough and very tough and unforgettable memories as PhD student at Tokushima University. Yeah, but we enjoy all the time as the PhD student there. So this is the references that I use on today's lecture. Maybe for the student who wants to know further, you can just download about this topic. The preferences of my talk, I will talk about the first is TMD, temporomandibular disorders, and then the manifestation and pathogenesis of TMJ rheumatoid arthritis, and also manifestation and the pathogenesis of TMJ osteoarthritis. So I'm going to start the lecture today. The temporomandibular joint disorders is also known as the temporomandibular joint syndrome that is involved the masticatory muscle, temporomandibular joint, and associated structures surrounding the TMJ. And the typical features of the TMJs is such as the pain in the TMJ, the restriction of the mandibular movement, the TMJ sound such as the clicking and crepitation, and the facial deformities or facial asymmetry. And then the etiology for the TMJ is very varying. For example, like the mechanical displacement, the traumatic injury, the biomedical, the osteoarthritis as the degenerative disease, the rheumatoid arthritis as the autoimmune condition, muscular problem, neuromuscular problem, psychophysiological, and also psychosocial. But several factors or either alone in combination are responsible for TMJ. And there are several common factors in TMJs. First is the predisposing factor. This factor could increase the risk of TMJ or orofacial pain. These factors such as the systemic condition, psychology condition, structural change on the TMJ, and also genetic factors. While the initiating factors for TMJ, this is the factor that caused the onset of disorder. For example, like traumatic injury, mechanical overloading of the joint, such as the perfunctional habits like bruxism, cleansing, and also perpetuating factor. This factor that interfere with healing or complicate management, such as the mechanical overloading, muscular stress, and also metabolic problems. Well, this is the classification of the TMJ. All TMJs divided into 4 broad categories. For the first is the masticatory muscular disorders. The pain in the masticatory muscle when we swallow, speak, or chew, and the pain increase with palpation or with manipulation of the muscle. And this disorder also associated with the restricted of mandibular movement. And then the temporomandibular joint disorders, such as the derangement of condyle disc complex, this displacement and dislocation with or without reduction, and also structural incompatibility with articular surface, the deviation on the TMJ, the condylar head form, and also dislocation. And then the inflammatory disorder on the TMJ, such as the synovitis, osteoarthritis, systemic arthritis, for example, like rheumatoid arthritis. And the next following factors is the classification, and this is the chronic mandibular hypomobility. It is characterized by the long-term painless restriction of the mandible because it can be caused by the ankylosis, muscle contracture, or coronate process impedance. And then the growth disorder. This is the disturbances in the growth that may be in the bone and the muscle, that common growth disturbance of the bone, such as the agenesis, no growth at all, and hypoplasia, insufficient growth, hyperplasia, and or neoplasia. And other common growth disturbances of the muscle, such as hypotrophy, muscular hypertrophy, and also the neoplasia. And then for the history and examination of the TMJ is to recognize the clinical sign and symptom. We have to concern about the first is this chief complaint about the location, the exact location of the pain onset, the characteristic of the pain, such as the dull pain, is it dull pain or the sharp pain, and the aggravation and relieving factor like a hot treatment, hot application, or cold treatment, and past medical treatment, if any, and how is the result of the medical treatment, and any other pain disorder. And the next is also the past medical and dental history, the general systemic assessment, and also psychological assessment. For example, like nowadays, the pandemic of COVID-19 has been reported that isolation and quarantine time could increase the incidence of neurologic and psychiatric symptoms such as post-traumatic syndrome disorders, anxiety, depression, fear, anger. Thus, it caused the increased risk of developing such as TMD condition. And then for the examination of TMD, the first we must do physical examination. Like we have to check the range of motion, if there are signs of bruxism, like sign of bruxism, and then the abnormal mandibular movement, the tenderness of muscular mastication on the neck and also on the shoulder. We have to worry about the pain with dynamic loading, and also postural asymmetry or facial asymmetry. And then for the clinical examination, both oral and dental examination, we have to worry about the sign of tooth wear or attrition. And the neurology examination and cranial nerve abnormality, if there's any. And then for the radiographic examination on TMJ, the first is panoramic to detect the acute condition, but sometimes panoramic is not enough to observe the TMJ condition. So we better to do computed tomography or CT scan to recognize the chronic and suspected structural abnormalities of the TMJ. And for the best radiographic examination, MRI, is also to detect the chronic and suspected structural abnormalities of the TMJ. And diagnostic cast. And then this is this example for CD and MRI. We can compare. In MRI, we can observe the shape of the disc, while on the CD, we can observe clearly about the position of the condylar head on the glenoid fossa. And then for the next examination is the MFA or manual function analysis to detect the TMD. This is the result of collaboration between dentists and the therapists. And its first purpose is to perform the screening for the dental treatment. On the left figure, this is cranially pressuring on the distal edge of the mandibular corpus. And then we need to do the dorsal passive compression. And then the manual diagnostic methods is very necessary to get the differential diagnosis on the muscular arthrogenic disorder, or on both determine the status of articular teeth and then the articular surface, and also to measure the passive capacity of mouth opening and making the specific diagnosis. And the sign and symptoms of TMD, first is pain, both TMJ and muscle, clicking and crepitation sound, the limitation of mandibular movement in all or part in mouth opening or closure, protrusion or lateral movement, the dislocation, displacement of the condyle from fossa, the dental symptom, tooth mobility, pulpitis, and then the otologic symptoms, the pain on the posterior articular tinnitus, itching on the ear, and the recurrent headache, such as pain and tenderness of the masticatory muscle along the temporal region. And for the treatment or management of TMD, the first is definitive therapy, like occlusal therapy, reversible or irreversible, emotional stress therapy, usually patient awareness therapy, restrictive use of mandible, voluntary avoidance to reduce tooth contact time, and relaxation therapy, and also supportive treatments such as the pharmacologic NSAID, corticosteroid, and physical therapy, thermotherapy, colon therapy, ultrasound. And then for the rheumatoid arthritis in general, rheumatoid arthritis is chronic progressive autoimmune disease characterized by the inflammation, primarily affects the peripheral joint and usually starts as a symmetrical left and right part. it has unpredictable and variable course, the pain and disability can be minimized if it is recognized early and treated promptly and appropriately. And for the pathophysiology of rheumatoid arthritis, like it includes multiple factors. The first is genetic factors, and the second is environmental factors. And also the presence of immune cells and soluble inflammatory mediators. This play important roles on the pathogenesis. And also the proliferation of the cell on the synovial layer of the joint, and followed by the infiltration of the cell by various cell populations and are orchestrated by cytokines, chemokines, growth factor hormones, and produce a locally invasive. And the next is the presence of the pannus formation. This is capable for invading and ultimately destroying the cartilage and bone. And then the clinical feature, the first is symmetrical polyarthritis in every part of the body, and the onset is most often insidious, can be episodic or acute, and the joint becomes swollen, painful, and very stiff. And the joint is usually more prominent and persistent than in osteoarthritis. So they're occurring at rest, night, anytime on activity. Prolonged early morning stiffness, also key diagnostic features such as the inflammatory disorders, and involve the cervical spine, causing pain in the neck, occipital headache. And this is also maybe as a result of the TMD and uncontrolled disease, another systematic disease, for example. Extraarticular features may involve multiple organs like lungs, blood vessels, skin, heart, and etc. And for the diagnostic criteria of rheumatoid arthritis based on the American College of Rheumatology, if we want to diagnose a patient that have RA must meet 4 or more criteria. That is includes the first is morning stiffness around the joint at least 1 hour, and soft tissue swelling, 3 or more joints, and swelling of the proximal interphalanx joint, metacarpophalanx joint, also wrist joint, symmetrical arthritis, subcutaneous nodules, positive tests for rheumatoid factors, and radiographic evidence of the erosions on the joint. And this is the figures of the arthritis on the TMJ. That RA leads to change in the jaw relation, such as this is anterior open bite, as we can observe on the left figure. It can cause also the limited movements of the mandible, joint stiffness, muscle spasm. And this, as we can see on the right figure, this figure shows that the loss of the condylar head, followed by the erosion and the narrow space between the glenoid fossa and the condylar head. So this is a challenge to dentists to detect the sign and symptoms, so the patient can get the early treatment for this disease. And then the arthritis in TMJ, the most common pathology affecting the TMJ is degenerative joint disease such as osteoarthritis. About 11 of 90% TMJs have symptoms of TMJ-OA. So TMJ-OA is more prone than TMJ-RA, whereas about 50% of joint revealed the radiographic signs of TMJ structural change, and about more than 30% of all orthodontic prosthodontics patients are adults. So the group that most likely to suffer from TMJ. Okay, so then this is the part of the interdisciplinary care team. So we have to make a collaboration between all specialists. So this is my paper related to the TMJ arthritis, as I focus on the fast apoptotic signaling pathway and also sphingosine 1-phosphate that activate the osteoclast, control subchondral bone remodeling on TMJ arthritis. And also there's a crosstalk on fast S1B1 and TMJ due to rheumatoid arthritis. I focus on the analysis of osteoclast cells that is like more extend on the lifespan of the osteoclast. So it can increase the osteoclast number, then leads on the TMJ's destruction. And then rheumatoid arthritis, as I said, that the characteristic is caused by the autoimmune disease, the expression of the leukocyte, and then auto-antibody production that attack the cartilage and bone destruction, and systemic features such as cardiovascular, pulmonary, physiological, and also skeletal disorder. So this is a figure comparing the arthritis joint and then the normal joint and arthritis joint. There's a bone erosion caused by the expression like osteoclast, fibroblast, macrophage, and another immune cells. While rheumatoid arthritis predominantly observed in the elderly, but some cases also found this exists on the young people, and the prevalence since 2002 is very few, about 0.5% until 1% of the population. Primarily affects the lining of the synovial joint, cause progressive, premature death, and also socioeconomic burden. The clinical manifestation, symmetrical joint involve arthralgia, swelling, redness. And then here is the figure of the pathogenesis of the bone destruction on the joint. As we can see, this is normal joint and this is the rheumatoid joint. The defect is started from the synovium. As we can see that the synovial macrophages produce inflammatory cytokines such as TNF-alpha, interleukin, and interleukin 1 and 6. This promotes osteoclast precursor cells. And on the other hand, the osteogenic T helper cell or T cell express interleukin 17. Expression of interleukin 17 induce synovial macrophage and also induce the synovial fibroblast. And this cell increase the RANK level on the tissue. RANK is necessary for osteoclastogenesis. The osteoclast precursor cell increase and leads to the mature osteoclast. The number of osteoclasts that exceed the normal, and it causes the massive erosion on the surface of the joint. And then this is for the intracellular signaling pathway of the osteoclast cells and the rheumatoid arthritis condition. In rheumatoid arthritis condition is characterized by the defect on the fast lesion. Therefore, the pro-apoptotic is inhibited and prone to pro-survival. The signal like RANKL ligand and then RANK system activates through NF-kappa B, activate the osteoclast differentiation and maturation. And then this is S1P if the cellular signaling movement for the cells, and the cells osteoclast is very active to move and to resorb the bone surface. And then the pathogenesis of RA specifically is the presence of absence of anti-citrullinated protein antibodies or ACPAs. The citrulination is characterized by the calcium-dependent enzyme peptidyl arginine deaminase (PAD), and more than 50% of rheumatoid arthritis patients express ACPAs. If the ACPA positive, the RA has more aggressive on the clinical phenotype than the ACPA negative. And the pathogenesis of RA, there's three main stages. The first is the triggering stage. The ACPA production has been associated with genetic. The main genetic is HLA-TRB1 allele. This is the shared epitope. And then also the environmental factors, for example, like smoking, habit, bacterial infection, and bad dietary. And then the maturation stage initiated at the site of the secondary lymphoid tissue or bone marrow. The epitope spreading refers to the development of immune response to endogenous epitopes, resulting for the release of the self-antigen. And immune response to autoantigen may exist many years before the disease onset and like onset on the joint. And this stage, the epitope spreading and gradually increase the titer of ACPA. That can last several years before the onset of the joint symptoms. And the last is targeting stage, normal synovial compartment infiltrated by leukocyte and synovial fluid is inundated with pro-inflammatory mediators. And here is the pathogenesis of RA. The first is the gene factors. The patient must have susceptibility genes, for example, HLA, and also has epigenetic modification and post-translational modification. And also from the potential trigger sites, environmental factors, noxious agents like smoking habit, periodontitis, bacteria, for example, like aggregative vectors, and then the gut microbiome, dietary factors, and self-protein citrullination promote PAD and calcium. And then in the maturation stage, the B cell and T cell express rheumatoid factors. And on the other hand, the granulocyte, the increased number of granulocyte tissue, granulocyte cells and macrophage cells express PAD induced, and then it also promotes the T cell to express rheumatoid factors. And the phases of development, the first is genetic background, and then environmental exposure, systemic autoimmunity. This is the expression of SCPA. And then the phase D, symptoms without arthritis, and then E, undifferentiated arthritis, and the phase F, we can diagnose patient with the rheumatoid arthritis. And then this is the several cells that engage with the rheumatoid arthritis. The first is endothelial cell, antigen-presenting cells, neutrophils, synovial fibroblast, B T cell, and also macrophage. The number of this cell increase on the synovial tissue, least bare area and attack the bare area and subchondral bone. The increased number of osteoclasts and synoviocyte, while the osteoblast and chondrocyte number cells were decreased. And then this is the animation of the temporomandibular joint rheumatoid arthritis. The defect started from the surface of the joint, infiltration of the inflammatory cells, and then also the osteoclast number, and then from the trabecular part of the mandible also promotes the increased number of the osteoclast, because the trabecular bone is the source of the mesenchymal stem cells. And then this is the case report, TMJ, rheumatoid arthritis on the TMJ. As then we can see on the right part, this is panoramic radiograph. There's no appreciable change on the condyle, while on the left side, it's not clear is there any defect on the condylar head. So we need to take another radiograph to be more precise. For example, like CBCT analysis of the condylar head. This is coronal view, closed mouth. As you can see here, slight decrease on the joint space. This looks like it looks normal, while on the left side here, loss of joint space and severe condylar erosion in this part. And it's followed by the CBCT coronal view open mouth. As we predict that norm on the right condylar looks normal, while on the left condylar head, we can see the massive erosion, and also followed by the narrowing the articular space. And CBCT from sagittal view open mouth to support our diagnosis, like in the left. On the left, condyle looks there, the head of the condyle is almost gone by the erosion. And here is the hand and wrist. We look, there are several changes on the in this bone, third and fourth metacarpal, while on the tibia bone looks, femoral bone, femoral joint looks normal also. While on TMGRA, to be concluded, the diagnosis of the MGRA is based on history. The first is physical findings, radiographic findings, and also the laboratory values for such as the rheumatoid factors or HCPA, and hematologically certain abnormal blood antibodies also to support the diagnosis. Other confirmatory tests like citrulline antibody and CRP tests sometimes are also needed, and radiographic changes on TMJ includes flattening on the mandibular head, cortical erosion, gradual decrease in the chain joint space, because of the granulation, the ossification, pencil head or spike, deformity of condylar head, and subcortical cysts. Well, now we're going to TMJ osteoarthritis. This can arise primarily by or secondarily as a consequence or other subtypes. For example, like this displacement, and is characterized by the progressive cartilage degeneration and subcondylar bone sclerosis. The rate of the progression is very varying from weeks to decades, and almost same with MGRA affect all of the tissue of the joint, like articular cartilage, synovium, subchondral bone, capsule, ligaments, etc. And the factors that have been proposed, like genetic or mechanical overloading, unilateral chewing habit, bruxism, parafunctional habit, and internal derangement. However, the molecular basis of the TMJ osteoarthritis etiopathogenesis remains unclear until now. So this is some research related to TMJ osteoarthritis, the analysis of the mandibular condylar degeneration by mediating chondroprotective effects of the ribamycin. This is the gastrointestinal drugs can downregulate the rankle-mediated osteoclastogenesis. And this is also the role of SMAD3 as sphingosine 1-phosphate signaling in mandibular condylar cartilage homeostasis. And this is the radiograph of the MGOA. So what is the difference with the MGRA? We cannot distinguish only by the radiograph. So in the figure A, this is the normal condylar head. Looks normal, even this looks like slight flattening on the head, but it's normal. The space between the glenoid fossa and the condylar head also looks normal. While on the B, figure B, there's an erosion and osteophyte formation. This is like spike on the condylar head. And then the concept of mandibular condylar resorption in TMJ osteoarthritis. On the normal joint, there's an adaptive capacity, functional remodeling to articular cartilage, and articular cartilage promote the functional remodeling. While on the TMJ osteoarthritis, there's a functional overloading cause the abnormal cartilages. The host adaptive capacity also reduced. And then the observation of mandibular condylar cartilage, specifically in the chondrocyte cells, to promote the increased number of vascular endothelial growth factors, also matrix metalloproteinase, while hypoxia-inducible factors decrease, so TMPS. Well, this also happened on the synovium, synovial cells, synoviocyte, promote synovitis, promotes the ROS, hyaluronic acid, and nitric oxide, cause the degradation of extracellular matrix, and then the cartilage leads to breakdown, condylar resorption, and might cause the mandibular clockwise rotation, mandibular retrusion, and so on. So this is the difference between rheumatoid arthritis and osteoarthritis. Rheumatoid arthritis focus the autoantibody production, while osteoarthritis mostly because of the mechanical overloading. So to be more simple, to make what is the difference between RA and OA, onset can happen at any age, while osteoarthritis usually later in life, onset for RA rapid, osteoarthritis usually slow. For distribution, rheumatoid arthritis symmetrical, polyarthritis, osteoarthritis usually asymmetric, while rheumatoid arthritis small joint, hand and feet usually, and usually attack all of the joint on the body, while osteoarthritis weight-bearing joint, for example, like knee, hips. And duration of the morning stiffness, for example, like is really worse in the morning, more than 1 hour, but for osteoarthritis usually less than 1 hour. And this is another different osteoarthritis and rheumatoid arthritis panels. Here we can observe that both of OA and RA medication by NSAID acetaminophen, and RA is drug-modified anti-rheumatoid drugs and also NSAID. While the difference on the panels, rheumatoid arthritis showed less mononuclear cell infiltration and blood vessel than rheumatoid arthritis panels. And osteoclast development for rheumatoid arthritis through RUNC and TNF-alpha signaling, while on the osteoarthritis only via RUNC pathway TRAP-positive cells larger than, or rheumatoid arthritis is larger than macrophage on the osteoarthritis, and also the lacunar reception on the rheumatoid arthritis is capable of extensive, while the osteoarthritis is almost the same. So here's the difference for the rheumatoid arthritis and osteoarthritis. It's normal joint. There's a thin cartilage. The distance between both of the bone is decreased, while on the rheumatoid arthritis, the defect started from the synovial lining surface, while the gap between two bone is looks normal. And this is the characteristic of osteoarthritis, is Panus formation, while the rheumatoid arthritis is periarticular erosion. Here is the same. This is different from the histological analysis. And this is the rheumatoid arthritis, and this is for osteoarthritis. Almost no different. Okay, this is another difference between osteoarthritis and rheumatoid arthritis. Muscle tenderness is more visible on the osteoarthritis than rheumatoid arthritis. So to conclude, a unique feature of TMJ, unlike the articular cartilage of the knee, cartilage of the mandibular condyle is considered as secondary cartilage. And the condyle of the mandible has lower amount of COL1A1 than another synovial joint. In contrast to articular cartilage of other joint, the superficial layer of mandibular condyle does not express COL2A1. And the articular surface are not composed hyaline cartilage, but only fibrous tissue. So these concluding remarks. In rheumatoid arthritis, the MJ is usually among the last joint to be involved, is associated with many clinical signs and symptoms. And the MJ rheumatoid arthritis involvement very varying in only from 2% until 88%. However, the majority of studies showed that approximately 50% of rheumatoid arthritis patients develop a clinical involvement of the TMJ. So that's it for my lecture today. Thank you very much.
Thank you, Dr. Islami, for such an illustrative lecture on osteoarthritis and rheumatoid arthritis and its effect on the degenerative joint disease of TMJ. Now, I will ask the audience if they have any questions to our speaker.
Hello, good morning, ma'am.
Morning.
Ma'am, I have a question.
Okay.
Ma'am, how can we classify rheumatoid arthritis as acute or chronic on the basis of radiographic examination? Like
rheumatoid arthritis as acute or chronic?
On the basis of radiographic examination.
Oh, okay. Okay, thank you for your question. So it's very difficult to detect if it's acute or chronic only by the radiograph examination. So if we want to detect is it acute or chronic, it's better to do the physical examination. So if it's still, for example, like the physical examination must be followed by the radiograph examination. But if it's only for radiograph examination, it's very difficult to detect. So we cannot detect the acute or chronic by the radiograph analysis, because the acute is usually, the characteristic of acute is the more the expression of the cell is like neutrophil, swollen, pain, hot, like tenderness or something. But in the chronic condition, the cellular characteristic is more like the leukocyte or T cells or B cells. So it's very different between acute and chronic. It cannot be detected only by the radiograph. So it's better to do like laboratory tests, or for example, like it's very difficult for a patient to have a histology for TMJ. So it's better to do laboratory tests like blood tests is better. If he wants to distinguish both chronic or is it chronic or a acute condition.
Okay, ma'am. Thank you.
Welcome.
Hello, ma'am. Good morning.
Morning.
Ma'am, what are the things that we should consider while giving a reversible occlusal therapy?
Sorry, reversible
Occlusal therapy.
occlusal therapy.
What are the
Pardon?
things that we should consider, like
Okay.
how long we should give or when should we stop it?
Okay. Thank you for your question. Yeah, when we should use the reversible. Usually in orthodontics, I used a bite plane. It's almost same like it's almost same like the reversible occlusal therapy. Bite plane is to release the contact to release the contact between the condylar head and also the fossa glenoid fossa. Sorry. So usually, if in orthodontics, usually if the patient have sign and symptom, for example, like clicking, the treatment by irreversible occlusal therapy could reduce the sign and symptom. It's very like 3 months. The clicking maybe usually gone. The patient has no clicking symptoms, clicking symptom again by using only 3 months. But if the patient has no clinic like clicking or crepitation sign and symptoms, and we use a bite plan to adjust the occlusal, and usually patient have a sign under TMJ. It's very like they experience pain when they use the bite plane on their TMJ because their TMJ is normal. It's like the adaptation phase for the TMJ because they're usually normal by the occlusion, and then when we put the bite riser on as the orthodontic treatment, removable treatment, they feel pain on their TMJ. So when we should, I think it depends on, we have to do a follow-up examination, like in every 1 month, we test the TMJ or we ask the patient if they still have the clicking or crepitation or pain in TMJ. If the symptoms, the patient has no symptoms, and then we can stop the occlusal therapy for the TMJ. But if the occlusion is still exists, when we can continue the bite plane therapy, for example, like that. So it's depend. We have to do followed instruction, followed examination usually until 1 year.
Okay, ma'am.
Now we have a question from one of our audience, Sidra Aslam. There are 2 questions. The first question is, how CRP is related to osteoarthritis since it increases in many other diseases?
Okay, thank you. Thank you for CRP is related to the rheumatoid arthritis. I guess it's not rheumatoid. It's not osteoarthritis. Yes, because in some cases, to convince that this in which stage of the rheumatoid arthritis, of the patient, we have to observe the blood like CRP. Like in my case, or in my presentation, CRP is related to rheumatoid arthritis. Since it's increased in many other diseases, how close it was for diagnosis? It depends on the severe level. I mean, severe level of which stage of the disease, for example, like rheumatoid arthritis. And then if usually if this patient showed a severe bone destruction, and the increased level of CRP usually increase. And also usually if they have sign and symptom and the joint arthritis, the level of CRP usually increase.
Are there any more questions from the audience? I think it answers your question, Sidra. There's one more question from Dr. Sajjad. What is the role of arthrocentesis of TMJ in rheumatoid arthritis or osteoarthritis?
I'm sorry, arthrocentesis is like same with atherosclerosis. Pardon?
No, arthrosentensis is not atherosclerosis. Arthrosentensis is
It's the lavage.
it is surgical lavage.
Arthrosentensis, surgical lavage of TMJ. Surgical lavage. Sorry, what is, pardon, I'm not sure about lavage mean. It's like erosion?
No, not erosion. It is okay.
It's the say joint cleaning with the saline or some other like fluid to get if we suspect some kind of pathology of joint, and we flush the joint with water, so all the inflammatory products come out of the joint.
Oh, okay.
Like it's like two syringes are placed, one will flush out, and from one we will inject the water and saline or water or any anti-inflammatory drug. It's same as joint injection, but because we are doing the lavage, so we are just taking the water out of the joint. It's like washing of the joint.
Oh, okay.
So how much helpful will it be in case of osteoarthritis or rheumatoid arthritis is the question. So
okay. Well, thank you for the question, Dr. Sajat. Well, I'm not sure about the arthrosentensis or washing of the joint, but when I did research on my PhD course, so I did this kind of like washing of the joint to detect about this infiltration of the cellular. I think it works. Yes, I think it works if we do washing of the joint or lavage of the joint, because it's really effective. But for the rheumatoid arthritis, since the etiology is the autoimmune, so it's very difficult to clear, to completely stop the infiltration of the cellular inflammation. Is really difficult. So once we flush, and then the infiltration, if there's any promoting factors, it can gain again. It can increase again the number of the inflammatory cells. So I think it's better to do it periodically. And then for osteoarthritis, it also depends on the severity of this disease. If there's a bone erosion, for example, for the bear loading because of the increase of the body weight, and then if the patient does not reduce the body weight, and then the burden on the joint, it's still if we cannot remove the etiology, so the lavage of the joint, if we flush the inflammatory cells, it's very difficult. It can reduce the sign and symptoms, but it cannot remove the etiology, I think. Since the molecular signaling of the osteoarthritis until now is still remain unclear. But there are many treatments to reduce the sign and symptom for the osteoarthritis, rheumatoid arthritis. There are many treatments, but to remove the etiology is very complicated.
Now we'll take two more questions. The first question is from Professor Sandhya Maheshwari ma'am. Is there any relationship of specific malocclusion in progression of osteoarthritis in TMJ?
Okay, thank you for the question. Yes, is there any relationship specific? Usually class 2 protrusive, maxillary protrusive, and the progression of osteoarthritis. Yes, usually in some research I read that the class 2 malocclusion have related to the TMJ, because I guess like on the paper said like some patients that have class 2 malocclusion prone to the defect on the TMJ, but for the exact mechanism, it's really still unknown. And then, for example, if the etiology is from TMJ, the first is etiology from malocclusion that leads the change on the TMJ, and the second is the TMJ defect on the TMJ leads to the malocclusion. So the relation between the malocclusion and progression of osteoarthritis depends on the etiology. Is it really from the TMJ or it comes from the malocclusion itself? So Is there any? Yes, is there any? And for the malocclusion itself, usually class 2.
And there's one more question. Can you throw some light on ICR, idiopathic condylar resorption?
Sorry, show some light. ICR. I'm sorry, what is ICR?
I'm
not sure.
It is
Idiopathic.
idiopathic.
Sorry, idiopathic condylar resorption. Okay, maybe when I was at the Tokushima University, my friends also asked what is about the idiopathic osteoarthritis or idiopathic arthritis on the TMJ. Well, I guess it's the etiology. It's also unknown, right? It's almost the same like when we studied about the rheumatoid arthritis, like there has gene susceptibility and genetic factors, and the analysis or the experiment about the genetic factors that cause the rheumatoid arthritis, and now it's only HLA-IDRB1, alpha trypsin, and then etc. And for the idiopathic, I think it's almost the same, like it's very genetic factor and supported by the environmental health. And I'm not sure about the ICR, sorry, but I think that's the point is the etiology. It depends on the factors, maybe genetic or supported by the environmental factor. Like we cannot predict, oh, must be from this part, must be from this part, but it is very difficult to precisely say, oh, this is the factors that probably main. So we have to check the genetic, we have to check if they're supported by the bad habit or anything. But for the histopathological analysis for rheumatoid arthritis or anything arthritis on the joint is almost the same. However, the intracellular signaling, both expression of usually for the osteoarthritis, the expression of hyaluronic acid, and then the HIF1, hypoxia-inducible factors, TIMPS, and that's the most protein that affected on the osteoarthritis. While on the rheumatoid arthritis, usually first the autoantibodies expression, and then the FAST gene on the osteoclast. I focus on the osteoclast, and defect is on the FAST ligand receptors, FAST ligand and the receptors of the FAST. And then maybe it's necessary to do more research on the idiopathic condylar resorption, I guess. It's a very interesting question. Thank you, Dr. Karpagavali.
Okay, thank you, Dr. Islami. Now we have some few multiple choice questions from Dr. Islami, which will be posted in the WhatsApp group. Now I ask Principal Dr. R.K. Tiwari, sir, to facilitate our speaker, Dr. Islami, with the certificate.
Dr. Islami, please accept certificate of appreciation for presenting your lecture under GIAN program and sharing your views and knowledge with the faculty of Dental College and the participants who has participated today in your lecture. Thank you very much.
Thank you very much.
Okay. We'll start. Okay. We'll start with the lecture 2 of our today's series. The topic of the lecture is measurement, quantification, and recording of pain. Pain measurement is an essential element in any medical assessment, including diagnosis, monitoring of disease progress, and evaluation of treatment effectiveness. Unfortunately, there is no one common or easy method of pain measurement. Since pain is a personal and private experience that cannot be seen or felt by others, the methods that must be used for pain assessment include indirect, self-report, physiological, and behavioral methods. The target of these pain assessments should be multidimensional. Pain is both somatic sensation and as an emotional state that evokes behaviors that minimizes bodily harm and promote healing. In this lecture, Dr. Professor Shaista Afroz will discuss in detail about the measurement, quantification, and recording of pain. So now over to Dr. Shaista for the lecture.
So can you see my slideshow?
Yes, yeah.
Okay. Thank you, Dr. Islami, for your very enlightening presentation. And I will go ahead with my presentation, which is about the measurement, quantification, and recording of pain. So we all know that it is very important to have the very important to record the pain, like all the other diseases. But it's very difficult because we know it is the patient's description. Most of the time it is because it is a subjective phenomena. So it is difficult to record. It's patient's description we have to rely on. We do not have a pain meter on which we can just check, okay, this patient has like a thermometer. We can say this patient has this much temperature. So we do not have, until now, unfortunately, we do not have any such objective way to measure the pain. It also depends on the clinician's judgment, how much his experience and expertise is in the field, and it cannot be quantified directly. We have to depend on the indirect measures of the pain. So as Virginia Woolf, one of the side researcher in the field of pain, she said, let a sufferer try to describe a pain in his head to a doctor, and language runs at once dry. So it shows words itself expressed that how difficult it is for the patient to express his feelings and for the doctor to perceive his feeling. So inaccuracies in description of pain occurs because of difficulty in finding appropriate words to describe the unique experience, and then it is very confusion about the features of this experience are relevant to the observer. How much observer is able to relate to the feelings of the patient is another factor, and then difficulties in remembering the experience. Of course, if we had a pain episode in our life at some point of time, we may remember, we may not remember the same thing. So it's difficult to relate to the patient's complaint. So what is the need for measuring or quantifying the pain? So first of all, to compare the pain intensity, we need to have a baseline data to which we can compare the others pain intensity. Then it helps in diagnosis, of course, and track the progression, and track the progression in the sense that we should be able to track whether the disease is increasing, which is causing the symptom of pain, or whether patient is responding to a particular treatment or not. So it is necessary to evaluate the clinical control, whether we are able to control the disease or not. It helps in communication between the doctor and the patient. So we cannot, every time our patient comes to the clinic, we cannot remember what he said last time. But if we have some kind of a scale or some kind of, as I said, like some kind of meter to measure the pain, we can record it, and we can, when our patient comes next time, we can relate to it and we can communicate with the patient. And of course, it improves the scientific understanding. Now, what should be the characteristic of any measuring tool? So it should be sensitive to the changes. That means, as I said, we should be able to track the progress of the disease or the effect of the treatment given to the patient. So it should be sensitive. And then it should be able to discriminate between different pain conditions. For example, somebody has inflammatory pain or somebody has neuropathic pain. So it should be able, that measuring device should be able to differentiate. Now it should be stable in time and not affected by experimenter testing a human volunteer in a pain experiment or a clinician taking the measurement from a pain patient. That means that anybody who is using that measuring tool is there is a consistency in recording, even though the clinician may be different or even though the experimenter is different. So there should be consistency in recording the pain. So it should allow the comparison in magnitude of changes due to treatment or pain conditions. I said it's the same thing as I said before. Easy to use. Of course, whatever is more easy to use, easy to learn, has more application in the clinic as well as in the research environment. So the learning objective of this lecture is to develop an understanding of various pain measuring quantifying tools or methods which can be used in the clinics and research. So there is no gold standard to compare human sensation by empirical measures, and indirect methods are necessary. So we know when we ask our patient, what is your problem? And he said, I have pain. So when we ask them, we ask him the question like where it is, what kind of pain do you feel, how intense it is, what are the factors which causes remission of the pain, what are the factors which aggravate your pain, what is the effect on your daily quality of life, on your daily lifestyle, and how frequent these symptoms are. So everything we are asking from the patient is answering, patient is telling. So this is subjective and nothing objective about all these information which we are getting. So when we use subjective, most of the time pain intensity is used to rate the pain rather than using the quality, location, or other factors. Pain intensity is the most common dimension of the pain which is used for pain recording. And these scales which only record the pain intensity are unidimensional scales. So what are those? There are several unidimensional scales given in the literature, but I'm picking up those which are most commonly used and which are easiest in clinic as well as research application. So these are visual analog scale, categorical verbal rating scale, and categorical numerical rating scales. So these are the most commonly used scale, and they measure the pain intensity and pain relief. And one more thing about these scale is that they can be used for short-term intervention, not for, though we use it for long-term intervention also, and for long-term follow-up patients also we use it, but they are best used if we are going or if we are planning for short-term intervention. And there is no check about their validity in case of chronic pain. So it is yet to be proved that they are the best scales for chronic pain. So what are these scales? So what are the advantages of these scales? Because they are unidimensional, we are not asking too many questions. So they are very quick, very fast. They utilize less chair side time, and they are very flexible. We can not only use them for measuring the pain, we can use them for other purposes also. So, and they help in communication with the patients. When their mouths, especially we are dentists, and when a patient is on the chair, so it's easy. You give him the tool, okay, you measure, you tell what is the scale of your pain today, and he can tell. And it increases the patient's understanding also, and the patient is more comfortable, and he gets more confidence in his doctor if such kind of tools are regularly used in our clinics to monitor and to record the patient's pain history. Easy to complete, administer, and score, can be used internationally without translation difficulties. So we don't need to translate them. So they are so easy to use, and they do not carry the risk of, like, if I say pain was 10 out of 2 out of 10, it will be 2 out of 10 for anybody in the whole wide world. But disadvantage is that it only measures the intensity, and especially it measures the intensity experienced in the last 24 hours, because most of the time patient will not remember what his pain was on a scale of 10 or on a scale of 100, what his pain was 1 week back, or how moderate, severe, whatever scale we are using, depending on that. It's difficult for patient to recall. Most of the patient cannot, some can. So it does not evaluate past pain experiences or fluctuation in pain. So these are the deficiencies of these kind of tools. Now this is on the first top. This is the visual analog scale, which shows on the left side, on the extreme left side shows the no pain, and on the right side, extreme right side, is the worst pain ever. So it is like on a scale of 10 centimeter, where, or you can say 100 millimeters. So you give the patient the scale and he will mark. It's a continuous scale. So we do not give him 1, 2, 3, 4, 5. We just give him the markings and he will mark, okay, this is the worst pain on the right side and this is the no pain on the left side. So where do you feel the pain today? So we will mark the pain and we can just calibrate it in terms of millimeter or centimeter. Millimeter is better, right? Because you have more number of millimeters. Now, another one is numerical rating scale. So again, it is just 1, 2, 3. So it is not continuous. You can see that patient can score 5 or can score 4. But if he has 4 and 5, in between 4 and 5, he cannot rate that. So 0 is again no pain and worst pain ever is 10 on this numerical rating scale. So it is not suitable for elderly and for very young children. It's difficult to communicate with them and tell them to rate their pain on a scale of 0 to 10. Now, verbal rating scale classifies the pain into 5 types: no pain, mild pain, moderate pain, severe pain, or unbearable pain. So this is again short and simple, and it can be used in case of both acute and chronic cases and suitable for all the groups of patients. So it is not so difficult to use these kind of scales. So these are a standard measurement would equate the maximum pain for all the individuals, irrespective of their subjective experience. So this is one big deficiency with these scales. I will show you in the next slide. So you see, all these visual, even visual analog scale or a numerical rating scale. So you see, this is a situation. If you see on the left side, patient A and patient B. For patient A, the worst pain is childbirth. But for patient B, the worst pain is stubbed toe. So we know the childbirth pain will always be worse than the stubbed toe. So that shows that, and if he rates the pain according to her experience, she her 0 to 10 is very big, and she rates it here somewhere. And then for this patient B, it's near. We convert it on a visual analog scale. So for both of them, the patient pain intensity is same. Pain looks equal for both the subjects, whereas it is actually greater for subject A because her endurance is higher. Similarly, if you look at another situation, so this is when the pain is less than 50%. But if the pain is somewhere like near 50% or more than 50%, if we try to compare, so what happens? In fact, the subject A has more pain than subject B, according to, if we think that worst pain is childbirth and worst pain is stubbed toe for both of them respectively. So when we convert it on a regular visual analog scale, we will see that what we see is a reverse of the amount of pain or pain intensity felt by the two patients. So even though the subject A has larger pain than subject B on a visual analog scale, it looks like subject B has more pain than subject A. So this is called as reversal artifact, and this is a very big deficiency of these visual analog scale. And other unidimensional scales are which are most commonly used for pediatric patients is Von Baker Faces Pain Rating Scale for people who cannot like they can see the picture and they can relate their feelings. So for those kind of patients, we can use this kind of scale. It is very popular in pediatric patients and older people. So like you can see there are a lot of emojis in one. Somebody's the emoji has those tears coming out of the eyes, showing that it is hurts worse. Whereas in the first one, it is a smiley face is there, so that means there is no pain. So patient can actually point out to how he feels today, and from the face expressions, and can tell how intense his or her pain is. So this is a very effective tool and very commonly used in pediatric patients. Now it was revised by IASP, International Association of Study of Pains, and they changed these 0, 2, 4, 6, 8, 10 calibrations, and then they changed that smiley face to normal expression. I don't know, because maybe it is said that it's better. A smiley face is not a good predictor when you are trying to calibrate the pain. So this is again appropriate psychometric property with elderly. It has strong validity and reliability, and it is good to use in the clinics as well as in research purpose. So now there is another unidimensional test which is called as full cup test. So it is you can make a diagram of a cup and show it to your patient. So when cup is full or cup is empty. When cup is empty, there is no pain. When cup is completely full, that means most severe pain is there. So patient can draw a line that how does he feel today. So how we can calculate the pain is we will take the edge, like the line, height of the line where patient has drawn the line to indicate his pain intensity on that particular day, divided by the height of the cup multiplied by 100. So this scale is reported in percentage. So it is good for uneducated people which have low education level, and it's difficult to explain them all the scales. So it is very useful tool, and we can use it in clinic and research both. And it can be used for differentiating the changes in pain as well. Now there are other pain scales. So there were several multi-dimensional pain scales introduced time to time to learn more about the pain, not only the intensity. For example, the associated factors, location and severity, chronicity, quality, contributing and distribution of the pain area, etiology of the pain if it can be identifiable, and mechanism of injury if applicable, and barriers to pain assessment. So these are all different kind of pain scales which were used, these were all the factors which were introduced in the multidimensional pain scales to get to overcome the deficiency of unidimensional pain scale. So most commonly used and most popular is the Magel pain questionnaire. It was introduced in 1971, and till date it is the most you can say comprehensive and the pain scale which is quite complete and have a lot of dimensions and a lot of recording features in it. So he developed a questionnaire, Melsack and Torgerson in 1971 developed the Magel pain questionnaire, and it was for using to evaluate a person's significant pain, to monitor the pain over the time and to determine the effectiveness of any intervention given to the patient. Now this scale has 4 major descriptors. That means there are 4 parts of this scale, and for like sensory, which records the sensory symptoms, affective, which records the unpleasantness, evaluative, and miscellaneous parts. And every part, like for sensory, there are 1 to 10 words which are used to describe how do you feel about your pain, which gives you the information about how much sensory disruption the pain has caused, and how much 11 to 15, that means 5 factors are there to know the affective evaluation, and then evaluative and miscellaneous. Similarly, so total there are 20 things we identify. And these sections which are there are what does your pain feel like is one thing, then how does your pain change over time, and how strong is your pain. So these are the factors, these are the information which we get by using this kind of Magel pain questionnaire. Now, if we see it in detail. So this is the questionnaire. I took this picture from the original paper. So this is like part 1 is this is a body picture. A pain drawing is included, and patient can point out or can mark it with a pen or pencil that what are the areas where he feels pain, and how does your pain changes with time. So there are descriptors like continuous, steady, constant, rhythmic, periodic, intermittent, brief, momentary, transient. So what kind of things relieve your pain? What kind of things increase your pain? And so then the part 2 is what does your pain feel like? That jumping, flashing, shooting, pricking, boring, drilling, sharp, cutting, lacerating. Likewise, there are a lot of words which helps in coming to a conclusion whether the pain is can be a neuropathic pain or can be an inflammatory pain. So just a rough estimate, but still there are a lot of descriptors. If you see 1 to 20 descriptors are there, as I described in the previous slide. Then last is how strong is your pain? Mild, discomforting, distressing, horrible, excruciating. So again, there are descriptors which were word describe your pain right now? It's distressing. Which word described it at its worst? It's excruciating. Which word described it when it is least? Mild. So this way the patient can complete the questionnaire, and we can have a lot of information about his experience. So it's quite exhaustive, right? And then along with this, there is another scale which is used. This is a part of McGill pain questionnaire. So that is present pain intensity scale. So it has 0 to 5 variables, and they tell about no pain to excruciating pain. So this is used along with that. So now, advantages of this McGill pain questionnaire is its reliability. It has high reliability, high validity, and then it is multi-dimensional. Disadvantage is that it is very complex, and it requires a lot of patient's compliance and endurance to fill the form. We know when patient has pain, he is so irritable that sometimes he may not even like to fill such a big questionnaire. It takes up to 30 minutes if you are sitting in a relaxed room and you and your patient are the only person talking to each other. Then also it takes 30 minutes just to fill the questionnaire, and then we have to do the examination, and then other things are required. So these are certain disadvantages. To overcome these disadvantages, a short form of McGill pain questionnaire was introduced, and which incorporates both the present pain intensity scale, which I showed previously, and visual analog scale. So it has 495 subscores, that is sensory, affective, total scores from the MPQ descriptor. So all the scores from the MPQ descriptors are used. Then overall intensity scores from the present pain scale, and present pain intensity scale and visual analog scale are combined together. So if you see, this is the short form of McGill questionnaire. It's like quite easy, not so big. So again, they are using the descriptors throbbing, shooting, stabbing, sharp, cramping, etc. to describe the pain. And then patient is asked, how does it feel? Like it's moderate or not at all, or severe or mild. So ranking is done as mild, moderate, or severe. So we saw how complicated it was, but short form is how small short form is. Then there is another multidimensional scale, which is Wisconsin Brief Pain Questionnaire. We can call BPQ, or so this is again used to estimate the prevalence and severity of the pain. Again, easy to administer, large number of patients. So we can screen large number of patients by using this questionnaire, self-administered. So if your patient, if you have it translated in your own language, local language, the patient can use himself or herself to rate the pain and write it, just fill it out. You don't need to assist him. It determines the history, intensity, location, cost, quality, and interference with activities. The disadvantage is it does not allow a comprehensive assessment of pain course. So you see the segments which are there. Again, pain drawing is used for all parts of the body: front, back, side, right side, left. And then please rate your pain by circling the one number that best describes your pain at its worst in the last week. So these are the questions which are included to know the characteristic of the pain. And then in the last week, how much relief have pain treatments. Again, the progression of the pain can be recorded. And then general activity, mood, walking ability, normal work, relations with other people, sleep, enjoyment of life does not interfere. So these are the various parameters which can be recorded with the help of this questionnaire. So again, it has that multi-dimensional feature with it. Now, another pain scale. Now it's when we have a patient which has a normal IQ and which can talk and which can interact with the doctor. So it's easy to take his recordings. But how about the little kids who cannot express themselves? And how about those elderly who have communication difficulties and who have intellectual disabilities? So for them, another kind of pain scale or universal pain assessment tool was developed, and it has verbal descriptor scale. But again, then facial pain scale is a part of it, where patient can describe as, okay, slow blink eye is severe pain. So it on visual analog scale, it goes 8. Right. Activity tolerance interferes with basic needs, and it has been translated in a lot of languages, and it is popularly used in the research as well as in clinic. So Now, out of all these tools which are available for measuring the pain, which one do you think we should use? So what should be the criteria for selection? So the instrument, first thing is that ease of administration. So anything which is very easy to use and has more patient compliance. The doctor should be comfortable. The dentist should have 100% confidence in using that scale and should be able, very swiftly should be able to apply that. So visual analog scale reported to have disadvantages in elderly as having more incorrect responses. This is reported in the literature. They said that visual analog scale when used in the elderly, so the tendency of reporting incorrectly are more. And this was again the findings of the research that it was easy to complete, but the percentage of missing responses in non-compliant patients in repeated administration is higher. So the patients had tendency to skip some of the questions. I don't know why. So if we look at the validity, of course, the criteria for selection should include the factor validity, if it is valid for that particular clinical applications or not. So visual analog scale, verbal rating scale, and numerical rating scale are valid to measure pain intensity. So in evaluating pain relief in short-term and intermediate periods of assessment of analgesics, but they are not, their validity has not been proven for long-term evaluation. So for evaluating short-term conditions, it's good. Now, sensitivity to treatment effects. So whatever the pain scale we are using should be sensitive enough to understand or to record the progress of the treatment. Should be able to show changes in pain intensity when a change is expected to occur. So they are quite sensitive and to record the pain intensity in short-term relief. Okay, again, the long-term application has not been proven. And then the multilingual and multicultural validity. So like I showed you the Mangle Pain Questionnaire and the BPI questionnaire. So if they can be translated into multiple languages, and they should be, again, the translation should be valid on that population. So it is important for multi-center international trials. So when we are doing a trial which is multi-centric in origin, so at that time it is necessary for us to select a scale which is valid and sensitive in others' population also, not only in ours. Now, it has been recommended by the researchers, some of the researchers, not everybody, that for long-term changes in pain, we said that we cannot use VAS, VRS, or NRS for long-term changes in pain and pain-related interference with function. So for their BPI short form can be used at intervals of 3 days to 2 weeks. And short-term changes and pain relief using VAS and RS 0 to 10 on a 0 to 10 scale administered 3 times daily for 4 days is the recommendation. But I'm not sure if they are universally acceptable recommendations or not. Now, the other tests which are available for quantifying the pain are quantitative sensory testing for orofacial dental pain. So why the quantitative sensory testings came into the picture, because there was a need was felt that we should have some instrument which can quantify and measure the pain objectively rather than depending on the patient's response. Of course, patient's response is very important. We cannot ignore that. His satisfaction and subjective reporting is always be on the top. But then objective measures are very important, especially where like small kids and adults with a language barrier or cognitive impairment is present. Otherwise, also we need to know, we cannot say if our patient is malingering, or we cannot say if there are some secondary gain which patient has in his mind. That is why he is telling, he's reporting that kind of pain. So it is necessary to quantify the pain, and the standardized test of perceptual and physiological reactions to external and quantifiable stimulus was the basis for developing these quantitative sensory testing equipments. So these are the physiologic measures for intraoral pathology. They are most precise to assess, there are certain physiologic measures. For example, they are used to, for example, pulp vitality test to assess pulp status. But the most precise is said to be the histology of the pulp. But that is not practical. Just now, Dr. Islami said that to understand if the changes in the TMJ arthritis are chronic or acute, we cannot check, we cannot take the tissues out and check. So same as with the pulp, we cannot take out the pulp and check if the progress is reversible or reversible. Then there are other tests like thermal, electrical, percussion, and palpation tests, which we commonly used. Most of the dentists use these kind of tests to check the pulp status. So they may tell about the pain also, but they are said to be more of a vitality testing when we are talking about the pulp, when we are talking about the odontogenic pain. Okay. Other equipments, other quantifying tools which were used were like pulse oximetry. So pulse oximetry, we all know, measure the oxygen saturation of the blood which is present. So it is reported that when it is pulse oximetry is used on the fingertips or any other part of the body, so the oxygen saturation, if oxygen saturation there was 99%, and if we use the same tool on the tooth, the oxygen saturation will be around 75 to 80%. We don't know what is the reason for this discrepancy. Then laser Doppler flowmetry is also used to check the red blood cells which are present in the pulp, which is again considered to be an indicator of, you can say, inflammation or vitality. But again, the deficiency of laser Doppler flowmetry is, or pulse oximetry, is that different enamel or dentine will have different optical property and different thickness. So how much these tools are sensitive in bypassing that change in the anatomy of the tooth, we are not sure about that. And another thing which has been used in the clinics are in the research is the temperature. So they said that if the pulp is a vital tooth and the non-vital tooth have same temperature, but when like a cold is applied, like cold spray is applied, so the vital tooth have tendency to come back to normal temperature more compared to the non-vital tooth. So it is acceptable because we know if it is non-vital, there is no blood circulation. So what is quantitative sensory testing? These are psychophysical tests. They are objective in nature. We have to depend partially from patient's response, but they are largely objective in nature. They quantify the physical stimulus that evoke behavioral like verbal responses, and we can use it on the mucosa as well as on the skin, and they can help in assessing the underlying mechanism of pain. For example, if we trigeminal neuropathic pain is there, so the feeling of hyposthesia to warm or cool stimuli may be there. If TMD patient has complained, so it has been reported that TMD patient most commonly complain of hyperalgesia on palpation or thermal stimulus. Advantages are these, that they are non-invasive. They do not consider patient's perception of stimuli. They do consider verbal responses necessary, but we do not have to depend on verbal stimuli. Disadvantage is that they cannot localize the lesion or the pathway, like which pathway the pain is taking. There we need to have a more advanced instrument. Patient cooperation is very important, and understanding the task, and of course, we will be able to implement it only if patient's compliance is high. And then we can use these kind of tools for longer assessment duration, in contrast to as we noticed in the unidimensional pain scales. Now, different modalities of QST are mechanical stimulation, 2-point discrimination, vibration, pinprick test, deep pressure test, and thermal stimulation. I will not go into the detail because I suppose this is an algometer which is used to apply the pressure on the skin or on the muscles to check the pain threshold or tolerance. Okay, so this is a very simple test we can use for 2-point discrimination, like using two dividers, one with the pointed end and one with the blunt end. And then we can use these thermal stimulators, thermodes, to check the thermal stimulation. Now, these QST measures have several measurements. They measure the threshold and they measure the tolerance. So threshold is like simple detection of pain in response to a stimuli, measured by asking subjects to report when they feel pain during a gradual and controlled increase in stimulus intensity, repeated administration of discrete stimuli of different intensities, and the threshold is defined as the average point at which subjects start to feel pain, or at least 50% of the subjects in a trial has pain at that level. So that is the threshold. Tolerance is to quantify the other end of the continuum of pain experience. That is, for example, in case of cold pressure test. So if a subject is asked to immerse his hand in a near freezing water, or temporary interruption of blood circulation in the palm. So here the tolerance is maximum duration or maximum intensity that a subject can endure. Now, magnitude estimations, after these tests, we can ask that how patient feels on a visual analogous scale or a numeric scale, and we can note down the rating. There are other behavioral responses in non-verbal individuals or small kids or cognitive impairment individuals can be used. For example, observation and quantification of a spontaneous behavioral responses evoked during pain. Challenge is that we cannot translate logic measures. It's difficult to relate the two together, and it has been shown that they have less sensitivity and they to interventions to diminish the pain. Now, physiologic responses were yesterday discussed by Professor Matsuka using like EMG or autonomic responses to non-visual stimuli. They are quite sensitive, but they are these responses like a heart rate, respiratory rate, or EMG of the masticatory muscles, if we say, for example, we are using to evaluate the pain, can change in other conditions also. Not necessarily it has to be a painful condition. Then they may be sensitive to analgesic intervention and characterize abnormal pain response, but it is not reported to be very high. Challenges are that as I said, it is not related to pain itself. There may be a stressful situation that may cause the change in the readings of EMG or autonomic response. And some responses may be reversed. For example, bradycardia in response to trigeminal system stimulation. So we are expecting that there will be trachycardia, but we are getting bradycardia. So again, it is not very reliable. Large individual variability. So they modestly correlate with subjective reports. So they are not very useful, but still they are there, and we can use them as a supplemental tools. Now, functional brain imaging is like upcoming methodology. It's said that pain causes activation of some of the areas of the cortices, insula, and anterior cingulate cortices, and we can record it. But again, we have to depend on the availability of these brain imaging or functional MRI to be present in our facility, and then they must be expensive, and they measure responses are proportional to the intensity of the pain reported by the subjects, and changes in pain induced by various interventions. For example, opiates, hypnosis, placebo reflect a modulation of activity of pain. So functional brain imaging it has definitely a future to evaluate the pain, but it has again its own deficiencies. Now, facial acting coding system. We all know coding systems are getting very popular in India. So right now, they were used in the past to, like, as I saw the reporting of the data in 1994, that was way before we even started our career. So they use neonatal facial coding systems for pain evaluation in newborn infants. So they, by using the cameras, they check the response, like the grooving of the face, nasolabial groove, or flattening of the lips, and frowning of the bulging of the forehead. So these changes in the facial expressions are recorded, but still they are not very popular, and they are not available for regular use. Even for research, they are very expensive also, and I hope artificial intelligence has a future. So let's hope if we come up with something better and something great to measure more objectively, the pain more objectively. So to summarize, I would like to say that quantitative tests which are available, like quantitative sensory testing equipments or methods, they are psychosocial methods. Questionnaire-based studies, a questionnaire-based method is both sensory and effective, and the complex psychosocial aspect of pain. It also measures the complex psychosocial aspect of pain, and brain imaging assess the neurophysiological responses associated with pain and reflect brain activity. So we can choose among all the available devices, depending upon the availability, depending upon our choices, our experience, and our skill. So that's it. Thank you very much.
Thank you, Dr. Shaista, for a very lucid presentation on measurement and quantification of pain. Now we'll ask the audience if there are any questions to our speaker. Are there any questions?
You can ask me.
Hello, Dr. Shaista.
Yes, sir.
Actually, you told so many scales. So, which one we should use in our clinic?
So, as I said, for short-term evaluation, unidimensional scales are good. If you want to record, if you know that your patient does not have any chronic problem and it will respond to analgesics, so unidimensional scales are best. And they're easy to implement also. But for long-term or evaluation and recording, and for chronic disease recording, multi-dimensional scales are the best. But of course, we need to practice before using them. Otherwise, we will not have enough confidence when we are using them on our patients.
I think so. You are there. You can guide us.
Thank you, sir.
Okay. Thank you.
Okay. Any more question? I will have a small question from speaker. My question is since different people have different pain thresholds, so when we are doing comparative studies, so how these skills can create a bias?
Yeah, very good question. Thank you, Dr. Abhinav. So actually, I saw in one of the slide that visual analog scale has inherent deficiency. That for somebody who has experienced more pain, so for them the range is high. But for somebody who has experienced less pain, his range is low. So they are, of course, biased. And we are saying that he reported 5 pain and he or she reported 5 pain, and we are giving the same amount of analgesic to both of them. So they're not the best scales for screening. For screening, I think multidimensional scales are better.
Thank you. Thanks a lot. We'll start with the lecture 3 of our today's series. The topic for the lecture is female predilection of pain. Are hormones responsible for physical and psychological perception of pain? Pain is a complicated experience that is influenced by many variables in the body, from how your nerves send and receive information to how much brain handles information about pain coming from the nerves, to how much inflammation is there in your body. In general, women experiences higher levels of pain and are more likely to have certain pain disorders than men. While we don't know all the factors that affect the pain experience, we do know that men and women's brains and bodies respond differently to pain. Hormones are said to play a role in women having more pain sensitivity. So in this lecture, Dr. Dalia Rafat will share her knowledge on the topic female predilection of pain are hormones responsible for physical and psychological perception of pain. Dr. Dalia Rafat is working as assistant professor in Department of Obstetrics and Gynecology, GIAN Medical College, Aligarh Muslim University, Aligarh. She is actively involved in teaching patient care and clinical research. Her teaching methodology includes lectures, tutorials, ward teaching, problem-based learning, case scenario discussions. She emphasizes on skill development of her students. Her thrust area is high-risk pregnancy and fetal medicine. She has published a book, chapter in a book, and published various papers in national and international journals. So over to Dr. Dalia for her presentation.
Dr. Dalia, unmute yourself.
Okay. Am I audible now?
Yes.
Yeah. Thank you, Dr. Abhinav, for such a kind introduction. And at the outset, I'm thankful to Dr. Shaista for giving me the opportunity to be part of this course, and would like to congratulate her for such a successful execution of this course. And I hope all those attending it will be really benefited, as am I. So without wasting further time, is my screen visible? Is my screen visible?
Yes, Dr. Dalia. Yes.
Okay. Okay. So as we have heard in previous lecture, various scales to measure, and as Dr. Shaista was emphasizing, that we can't give same analgesics for the same amount of response. We need to measure the pain. Besides just knowing that they're measuring pain, what else is also important is to know that pain is not same in all conditions, and to throw more light, especially on sex predilection of pain. I will be taking you through that. And before going in detail, I would like you to go through the scenario where a 26-year-old female university student presented to her dentist with complaint of recurrent pain in her mouth. I hope many of you dentists would be getting such students or patients. And the pain comes and goes, is more intense in the presence of stress and fatigue, and particularly around school examination period. The dentist, after thorough evaluation, told that she has no identifiable signs of disease, and he also advised that the type of pain she is experiencing is common among women and could be psychosomatic. Now, the trainee who was assisting the consultant wondered whether her consultant is right and correct in saying that the pain is just really a woman's condition, or there is some definite biological reason for it. Going back to his clinic, he started remembering some thoughts which he came across few days, that pain is just a state of mind. You can think your way out of everything, even pain. And the pain of the mind is worse than the pain of the body. Now, is it really so? And is the pain has to do only with the state of mind, or are there any other biological reasons associated with it? So to clear off all these queries, we will be spending next half an hour, and the objectives of the class, of the session, will be to define 6 differences in clinical pain with an emphasis on perception, experience, and manifestations of pain, review potential causes of 6 differences to pain perception, and delineate differences in pain experience between males and females, and discuss role of hormones in physical and psychological perception of pain. Now, pain, as has been defined by ISP, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage and described in terms of such damage. So to notice that pain does not require tissue damage, it is unique to each individual, is influenced by external and internal stimuli, and is influenced by race, ethnicity, culture, and sex. Pain is thus a complicated experience that is influenced by many variables in the body, from how your nerves send and receive information to how your brain handles information about pain coming from those nerves, to how much inflammation is there in your body. And as Dr. Dance has said, that even though everybody's pain might look similar from the outside, scientists can't assume it's the same on the inside. And there has been escalating interest in gender and sex-specific treatment in medicine and pain, with this field being gradually advancing towards identifying ways to apply available knowledge of sex and gender-related differences for pain treatments. And it is expected that the future will witness more novel treatment strategies and prevention with a focus on sex and gender-based treatment of pain. Sex and gender differences in pain have been a point of focus since long in the medicine field and continue to gather increasing interest. Differences in pain perception have been examined extensively in the lab, and assessments of experimentally caused pain indicates sex discrepancy with female predilection. While we don't know all the factors that affect the pain experience, we do know that men and women's brains and bodies respond differently to pain. So there definitely is a pain gap. And after decades of assuming that pain works the same way in all sexes, scientists are finding that different biological pathways can produce an ouch. So coming to sex difference in pain perception, studies have shown that females have higher pain sensitivity than males, as they possess less efficient endogenous pain inhibitor capacity than males. Also, these results have been found among a variety of experimental pain modalities. As concerns severity of chronic pain, females also report more severe pain than males. Regarding frequency of pain, females report more frequent bouts of pain than males and have longer lasting pain compared to males. As far as distribution of pain is concerned, pain is more anatomically diffused among females than males. But they are better at discriminating painful sensation, and they experience less tolerance to pain with lower thresholds. Also, they rate pain higher than males. Besides this, women are more likely than men to have comorbidities that may impact the risk of developing chronic pain, either through modulation of pain perception or an impact on behavioral response. It is, however, unknown if these comorbidities contribute to or a result of heightened sensitivity or an increased exposure to painful stimuli. So what all types of clinical pain females are predisposed? Generalized pain, musculoskeletal pain, autoimmune disorders, headaches, and gastrointestinal pain. But not all painful conditions are perceived more in females. There are few, and at fewer age range, which are perceived in more males. taking first into conditions which are more painful in females, osteoarthritis and gouts and other arthritis are more painful in females in older age, especially more than 45 to 60 years, whereas they are more painful in males in younger age groups like osteoarthritis less than 45 years and of gout in less than 60 years. Besides that, fibromyalgia, temporomandibular disorders, GI upsets, migraine with aura, Raynaud's disease, and carpal tunnel syndrome have more predilection for in females, whereas conditions like ankylosing spondylitis, pancreatitis, cluster headaches, and migraine without aura have more predilection in males. But there are, now I would like to throw some more light on oromaxillofacial pain, which has high prevalence in females, as we have been heard in various lectures since yesterday. Females are more likely to seek medical care also for TMJ pain, and they have greater susceptibility to develop ongoing pain and simple pain sensitization in rat models of TMJ pain. Researchers have proposed that the higher frequency of chronic orofacial pain in women is due to 6 differences in generic pain mechanism, as well as yet unidentified craniofacial system specific variables. There are few exceptions to this generalization, like conditions like oncologic pain and few post-operative pain, which don't show any sex predilection and are demonstrated to be present, are not demonstrated to be present differently between males and females. Now we have heard that, okay, there are more predilection of pain in females, but what all factors contribute to this pain perception? They can be biological mechanisms, neurological, endocrine, psychological, emotional, socio-cultural, coping mechanism, expectations, all playing side by side or contributing towards female predilection of pain. Besides that, the repeated exposure of viscera to painful events in life of a female, like menstrual cycle, pregnancy, delivery, predispose them to various painful conditions. So this is a pictorial representation of the previous slide, where all the factors contributing to sex difference in pain have been shown. Now, I will be talking in detail about role of hormones, especially sex hormones in pain perception, and studies or the facts which favor this fact that sex hormones have role in pain perceptions are that studies have demonstrated that there is exacerbation of clinical pain across the menstrual cycle. Exogenous hormone use increases risk for some types of clinical pain and reduces menstrual cycle effects on experimental pain sensitivity. Also, experimental pain sensitivity changes across the menstrual cycle with increased sensitivity to most pain modalities during luteal phase relative to follicular phase. Now, as far as effect of androgens on pain perception is concerned, it is quite clear, with testosterone appearing to be more anti-nociceptive and protective in nature, primarily through an impact on inflammation. Whereas the clinical impact of aromatase activity and secondary production of estrogen, however, can make these results about isolated role of testosterone challenging to interpret. As far as progesterone is concerned, its role is relatively complex But by far it is anxiolytic, sedative, and has analgesic effects and modulates pain. Now coming to estrogen, it has long been found to affect the sensory and pain systems, but the exact role is still somewhat unclear. Estrogen receptors are found in almost all cells and tissues, including spinal cord and areas of brain that perceive and interpret pain. And animal models have demonstrated an impact of estrogen on serotonin synthesis and reuptake, new opioid receptor availability, hippocampal excitability, anxiety, as well as stress. But studies have variably found that estrogen increases or decreases the response to pain or has no effect. Now, these contradictory results may be due to the different species, pain models, and protocols applied in different experiments, the different types of estrogen receptors mediating different estrogenic effects, the nociceptive effect of estrogens being dependent not only on its presence, but also on its dynamic modulation at the system level. Thus, to summarize role of sex hormones on pain perception, there has been copious evidence that sex hormones affect pain, and this may be at least in part responsible for different sex predilection of pain. But the relationship is not a simple one and is likely to involve dose-dependent organizational and activational effects and actions at a number of sites outside the reproductive system, as well as effects on disease processes themselves. There may be interaction between other different hormones. Thus, it is important in future pain studies that both sex and hormonal status of the subjects be taken into account. Now, throwing some light on other factors besides hormones which may contribute in pain perception, there can be psychosocial factors like higher levels of masculinity related to femininity has been associated with increased pain tolerance, and feminine gender norms accept pain as normal part of life and are more permissive of pain expression. Also, there is greater anxiety sensitivity in females and more symptoms of depression in females compared to males. Coming to cognitive factors, the phenomena of catastrophizing and self-efficacy are two important factors responsible for pain perceptions, with women being more likely to respond to stress and pain through catastrophizing and report lower self-efficacy compared with men. So when these two phenomena are controlled, the pain differences in pain perception between genders gets diminished. Also, behavioral effects contribute to pain perception. For both painful and non-painful disorders, females are more likely to seek healthcare services. Also, they are more likely and willing to report pain on various surveys and trials, whereas males tend to overestimate their tolerance of pain as they tend to believe that they are more tolerant of pain compared to females. So, key takeaways from this session will be that the gender differences in pain perception are variable and complex. There are several independent factors contributing to the quantity and quality of responses to painful stimuli in females versus males, and results of most studies do show female predilection for pain, but not for all experimental and clinical conditions. However, it's unclear If these apparent differences are due to variances in how men and women respond to pain, social conventions for expressing pain, or biological differences in how noxious stimuli are processed. Also, while several studies have attempted to address this controversy, the different patterns of sex-specific prevalence for various clinical pain disorders and the inconsistencies in the findings across experimental studies highlight the fact that gender issue is still unresolved and needs further exploration. And as clinicians and researchers, one must be aware of potential gender bias on both the patient and physician or experimenter sides in order to interpret, treat pain, and analgesia response accordingly. And thus, I will conclude with this, that a deeper understanding of pain and its differences based upon sex are important in the way physicians address pain clinically in order to best serve patients of both sexes in varied situations. Thank you. These are my references and suggested reading too.
Thank you, Dr. Dalia, for throwing light on the role of hormones for physical and psychological perception of pain in the female patients. So over to the audience for any questions to our speaker. So any questions to our speaker? I think there are no questions from the speaker, for the speaker. There's one question. Yeah, there's one question from Dr. Sidra Aslam. ONPY perception or intensity also varies. Only perception or intensity also varies. I couldn't get the question, Dr. Sidra. Perception or intensity also varies. Okay. I think the question is for the female patients, both the perception, is it the perception or the intensity also varies in the pain?
Yeah, as I have pointed out, not only perception, its intensity, its duration, studies have shown they vary. If distribution varies.
So, Dr. Dalia,
yeah,
I have read certain reports like patients with polycystic ovarian diseases have more prevalence of TMD, temporomandibular joint disorder, which is again a painful condition. So is it hormonal imbalance which is responsible, or it's the disease itself makes them so debilitated that they are more prone to any kind of different organ this pain predilection?
Yeah, that is the main crux of my thought, which I wanted to emphasize, that although this controversy is still not settled, because there are many conditions which predispose for females to be sensitive for this pain. So we can't attribute it clearly 100%. That it is only because of hormonal imbalance, although there have been reports suggesting that the hormonal imbalance, those who have more hormonal imbalance are more susceptible to those pains, but they are susceptible to other stimulus also. So it is still not clear if it is only hormonal imbalance which is leading to this more susceptibility to pain. Needs to be worked upon. This area, this thing needs to be worked upon.
Yeah, exactly. There are a lot of animal studies which are done on these kind of like null mutation and genetically modified models where suppression of the genes were caused, but
Yeah.
still no conclusion has been drawn from those studies also. Or
Still no
translation
conclusion.
is
Yeah.
not there, so
I
we cannot
was-
say.
Yeah, I was reading our article for this presentation only. First line which the author has written was that the experimenter or the researcher himself got severe headache after working on this sex predilection for pain when he was working on animal model. He himself, it is the first starting line of that. So definitely, but needs to be worked upon, because when in animal models, this gender differences are not taken into account when these are when the experiment is planned and when the reports are interpreted. Even they have said that the interpreted bias of sex is also there, so that interpreting the results. So
yeah, exactly right. Thank you for the nice talk.
I have one question, Dr. Dahlia.
Thank you.
Hello. My question is age also a factor among the female patients? Because like older females, there are more hormonal differences as compared to the younger patients.
For few, what studies have shown that for few pains, age definitely is a factor, whereas for few, it's not. Like for orofacial pains, they say that across all age groups, females have more predilection. Whereas for conditions like osteoarthritis, they say that at younger age groups, males have more predilection to pain for such pains, whereas females have more predilection at older age groups. So for few categories of pain or for few types of clinical pain, age is not a bar, and females at more risk throughout their lifespan. But for few types of pain, definitely studies have suggested that they are according to age groups.
Thank you, Dr. Dahlia.
Ma'am, I have a question. Ma'am, is there a term like pregnancy-induced analgesia, like the in which that some
actually, yeah, because of higher levels of progesterone, which has sedative effect, anxiolytic effect, and to some extent analgesic effect. There is some school of thought which says that few pains get depressed or suppressed because of these hormonal influences in pregnancy, but not for all types of pain.
Like, ma'am, like
For
what kinds? Like
Sorry?
arthritis, osteoarthritis, and all.
Yeah. Because of the changes in hormonal status, there is some betterment of few types of pains, especially rheumatoid arthritis and autoimmune disorders. So the change in hormonal milieu points towards that for few pains there is betterment, definitely, but not for all pain categories.
Okay, ma'am. Thank you.
So we'll start with the, I think, any more questions? Any more questions to our speaker? I think we are done with the questions, Dr. Dahlia.
Okay.
Thank you. Thank you for the presentation.
Thank you.
So we'll start with the lecture 4 of our today's series, diagnosis of acute and chronic orofacial pain conditions and the case study. After thorough examination, we should diagnose the patient pain and condition. In this lecture, Dr. Professor Yoshizo Masuka will share his knowledge on the topics: diagnosis of acute and chronic orofacial pain condition with international classification of orofacial pain, non-odontogenic toothache, and diagnosis of some cases. So over to Professor Masuka for the next presentation.
Thank you, Dr. Abhinav. Thank you. So I will show my slides. So can you see my slides? Dr.
Yes,
yes,
it's visible, sir. Yeah.
Okay, thank you. So today, this time I will talk about the diagnosis of acute and chronic orofacial pain condition, and also I will show the case study. And this is the cherry blossom pictures in Tokushima. So this is the time to have the cherry blossom. So you should come to Tokushima now. All right, diagnostic classification system. There are several types of the classifications. WHO, IHS, and also the ICOP, International Classification of Orofacial Pain, and also the American Academy of Orofacial Pain. Also, yesterday I talked about the DCTMD. Today, so I will through the International Classification of Orofacial Pain. So first, yesterday or the day before yesterday, I showed this slide many times. So first, for the diagnosis, you need to know that these kind of things, again, location, reason, what triggered the onset of pain, progress, quality, intensity, frequency, duration, daily fluctuation, aggravating factor, alleviating factor, associated symptoms, and behavior. We need to ask the patients. All right, so international classification of orofacial pain, I showed also, and one is orofacial pain attributed to disorders of dental alveolar and anatomically related structures. Two, the myofascial orofacial pain. Three, the temporomandibular joint pain. Four is the orofacial pain attributed to lesions of disease of cranial nerves, trigeminal neuralgia, glossopharyngeal neuralgia, etc. And orofacial pain resembling primary headache or orofacial migraine, tension type orofacial pain, and also the number 6, the idiopathic orofacial pain, burning mouth syndrome, persistent idiopathic facial pain or dental alveolar pain. Number 7 is the psychosocial assessment of patients with orofacial pain. So number 1, orofacial pain attributed to disorders of dental alveolar and anatomical related structures. Again, it's a dental caries or periodontitis. Also the oral mucosa, salivary glands, bone pain, etc. So diagnosis and treatment is a dentist specialty. So you do every day these kind of diagnosis and treatment. So I don't need to talk much, right? So number 2, let's move to the myofascial orofacial pain. Description: the pain is muscular muscles with or without functional impairment, not attributable to another disorder. So yesterday I talked this also. So the myofascial pain fulfilling criteria B2D occurring in one or more episodes, and jaw, temple, ear, and or in front of ear, and they require both of the following, 1 and 2. So temporalis and master muscles. 2 is provoked by palpation or jaw opening movements. And these are modified by jaw movement, function or parafunction. And episodes may be single or recurrent within any day, and lasting at least 30 minutes. All right, and pain, primary myofascial orofacial pain, pain of muscle origin is modified by jaw movement, function or parafunction, and replication of this pain is elicited with provocation testing of the temporalis or master muscles. So palpation is a testing, which are the muscles involved with highest prevalence. So again, I will talk you again, the myofascial orofacial pain, the most highest prevalence in the orofacial pain. And also you can see the many muscles in the facial area. So you need to think about which muscles, but usually people have the master muscle or temporalis muscle pain. Number 2, secondary myofascial orofacial pain is the criteria fulfilling C and D, but secondary myofascial orofacial pain has the underlying disorder known to be able to cause myofascial pain has been diagnosed. And the other thing is same as the 2.1 original, what's the name of primary myofascial orofacial pain, same as C and D are same. The disorder is specified in each subforms. These signs may be demonstrated during physical examination or in the case of pain that has already resolved, reported in the history. Okay, so number 3 point, so move to the temporomandibular joint pain. 3.1, primary temporomandibular joint pain. Pain localized to the temporomandibular joint occurring at rest or during jaw movement of palpation with no known causative disorder. The diagnosis corresponds fully to DCTMD diagnosed temporomandibular joint pain. So we need to know the DCTMD here. So diagnostic criteria. Fulfilling criteria B to D. B, occurring one or more episodes, and C, both of the following. Temporomandibular joint pain provoked by a palpation of the mandibular condyles and also the jaw opening, modified by jaw movement, function, or parafunction. So episodes may be single or recurrent within any day, each lasting at least 30 minutes. That is a primary temporomandibular joint pain. Or secondary temporomandibular joint pain, pain localized to the temporomandibular joint and caused by another identified disorder such as inflammation, sensitization of tissues, structure change such as osteoarthritis or displacement or subluxation or injury. Diagnosis criteria, fulfilling criteria C and D. But before C and D, B, underlying disorder known to be able to cause temporomandibular joint pain. And C, all the following three characteristics, located TMJ, and also provoked by palpation, maximum assisted, maximum jaw opening, modified by jaw movement. That is a secondary temporomandibular joint pain. And D, evidence of causation demonstrated at least two of the following. The pain has developed in temporal region relation to onset substantial worsening of the presumed causative disorder. The pain has significantly worsened in parallel with progression of the presumed causative disorder. 3, improved or resolved in parallel with improvement. So that is a secondary temporomandibular joint pain. And diagnosis according to the expanded DCTMD taxonomy definition. So also we need to know the DCTMD. So the secondary temporomandibular joint pain include disc displacement with reduction. This is a with reduction. And also the disc displacement without reduction. So if patient has this kind of the temporomandibular joint problem, and if patients say they have the temporomandibular joint pain, it's a secondary temporomandibular joint pain disorder. Also, here I show the degenerative joint disease. All right, so temporomandibular joint pain and diagnosed pain the temporomandibular joint caused during jaw movement, reproduced by palpation of temporomandibular joint, and MRI showed the disc dislocation I showed yesterday. Also, the X-ray photograph was CT, the temporomandibular joint deformation. Regarding the management, I will tell you tomorrow, right? But roughly the explanation of pathological condition, lifestyle guidance, NSAIDs, Chinese herbal medicine sprint is L, right? Sorry, injection of the temporomandibular joint, etc., etc. Okay, move to the 4.1 trigeminal neuralgia. A disorder characterized by the recurrent unilateral brief electric shock-like pains, but abrupt in onset and termination, limited to the distribution of one or more divisions of the trigeminal nerve and triggered by innocuous stimuli. And diagnostic criteria: recurrent paroxysms of unilateral facial pain and the division of the trigeminal nerve. The pain has all the following characteristics, lasting from a fraction of a second to 2 minutes, very short time, and severe intensity. And also 3, electric shock-like shooting, stabbing, or sharp, precipitated by innocuous stimuli. It's okay. And 4.1.2.2, trigeminal post-herpetic neuralgia. Description: unilateral facial pain persisting or recurring for at least 3 months in the distributions of one or more branches of the trigeminal nerve with variable sensory changes caused by herpes zoster. Diagnostic criteria is unilateral facial pain and trigeminal nerve branch and more than 3 months. And herpes zoster has affected the same trigeminal nerve branch, and pain developed in temporal relation to the acute herpes zoster infection. Usually, pain will have developed while the rash was still active, but on occasion later, after the rash has healed. In such cases, pale or light purple scars may be present as a scare of the herpetic eruption. Okay, next one, the post-traumatic trigeminal neuralgia, unilateral or bilateral facial or facial pain following and caused by trauma to the trigeminal nerve with other symptoms and or clinical signs of trigeminal nerve dysfunction and persisting or recurring for more than 3 months. Diagnostic criteria are more than 3 months and both of the following: history of injury to the peripheral trigeminal nerve, also the diagnostic test confirmation of region of the peripheral trigeminal nerve explaining the pain. Onset with 6 months, within 6 months after the injury. So the pain came within 6 months after the injury, associated with somatosensory symptoms and signs in the same neuroanatomical positive distribution. That is a post-traumatic trigeminal neuropathic pain diagnostic criteria. And also the number 5, migraine, headache, sorry, orofacial pain resembling presentations of primary headaches, orofacial migraine, tension type orofacial pain, and also the trigeminal autonomic orofacial pain includes the orofacial cluster attack, paroxysmal hemifacial pain, also the short-lasting unilateral neurological facial pain, and neurovascular orofacial pain, short-lasting neurovascular facial pain or long-lasting. So this is a kind of the, I told you yesterday, headache, migraine and tension type headache. And episodic orofacial pain, orofacial migraine. So same as the migraine diagnostic criteria, and at least 5 attacks, fulfilling criteria B to D, P, lasting 4 to 72 hours. Pain has at least 2 of the following: unilateral location, pulsating quality, like dun, 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 like this, moderate or severe intensity, aggravation by routine physical activity, walking or climbing stairs. Pain is accompanied by one or both nausea and or vomiting, photophobia and phonophobia. All right, and chronic orofacial migraine means occurring on 15 or more days per month for more than 3 months. So that is a chronic orofacial pain migraine. So criteria B to D for 5.1, episodic orofacial pain migraine, and more than 8 days per month for more than 3 months. That is a chronic orofacial migraine. Tension type orofacial pain. The episodic or chronic pain exclusively in the orofacial region without head pain with the characteristic and associated features of tension type headache described in ICHD3, International sorry, headache classification. So again, if also you need to know the ICHD classification sometimes. And chronic tension type headache. Chronic tension type headache is more than 15 days per month and average for more than 3 months, lasting hours to days on unlimiting. And at least two of the following four characteristics. Bilateral location, pressing or tightening, non-pulsating quality, mild or moderate intensity, not aggravated by routine physical activity, such as walking or climbing stairs. So if the patient has two characteristics, that it's number 3 is okay. Oh, this is the A, B, C, D, E. Sorry, not 1, 2, 3, 4, 5. A, B, C, D, E. So D, both of the following. No more than one of the phonophobia or mild nausea. No more. Neither moderate or severe nausea nor vomiting. That is a chronic tension type headache. Okay, move to 6. Burning mouth syndrome, persistent idiopathic facial pain, and persistent idiopathic dental alveolar pain, also the constant unilateral facial pain with additional attacks. That is, again, the classification is not so clear. So, yeah, so again, I told you 2 days ago, maybe in the future, they will change the classification with more research. So the description, intraorbital is a burning mouth syndrome. An intraoral burning or this aesthetic sensation recurring daily for more than 2 hours per day for more than 3 months without evident causative lesions on clinical examination and investigation. Diagnostic criteria, fulfilling criteria B and C. B, recurring daily for more than 2 hours per day for more than 3 months. Pain has both of the following characteristics: burning quality, felt superficially in the oral mucosa, and oral mucosa is normal appearance. That is a burning mouth syndrome. Persistent idiopathic facial pain. It's very similar diagnostic criteria of the burning mouth syndrome, but persistent facial pain with variable features recurring daily for more than 2 hours per day for more than 3 months in the absence of clinical neurological deficit preceding causative event. So B and C, same. Pain has both of the following characteristics: poorly localized and not following the distribution of the peripheral nerve, dull, aching, or nagging quality. Clinical and radiographic examination are normals. That is a persistent idiopathic facial pain. And this is a persistent idiopathic dental alveolar pain. I think you see some patients I saw, but if you remember clearly. So please remember the difficult patient clearly. Description: persistent unilateral intraoral dental alveolar pain, rarely occurring in multiple sites with variable features, but recurring daily for more than 2 hours. It's same. And criteria B and C. B and B is same, and C both. Localized to dental alveolar site, tooth or alveolar bone, and deep, dull, pressure-like quality. So patient complain dull, deep pain in the teeth, 2 hours per day, more than 3 hours, more than 3 months. And also clinical radiographic examination normal, and local causes have been excluded. So you couldn't find dental caries or periodontal disease. So you can diagnose the persistent idiopathic dental alveolar pain. I think, yeah, but if also you need to remember not better accounted for by another ICOP or ICHD3 diagnosis. You need to think about. And consistent unilateral facial pain with additional attacks is fulfilling criteria B. Both of the following: mild to moderate intensity, constant present for more than 3 months. but exacerbation occurring as a distinct attacks up to 6 times daily in the same location as the background pain, moderate to severe intensity, lasting 10 to 30 minutes. Clinical radiograph examination normal. All right, number 7, psychosocial assessment of patients with orofacial pain. Major psychological factors associated with pain disorders include anxiety, catastrophizing, depression, physical symptom reporting, and fear avoidance. All right. So that is a international classification of orofacial pain diagnosis. So again, you can read, you can download through the internet these things. And if you have the difficult patient, you need to read the ICOP classification carefully, and you will. I hope you will find the patient problem that is important for the diagnosis. And also, do you remember the non-odontogenic toothache? The same as here. The persistent idiopathic dental alveolar pains, also the non-odontogenic toothache, but there are some review and some reports regarding the non-odontogenic toothache. So the tooth doesn't have any problem, but the patient complain the pain, toothache. So there are several classifications. Myofascial pain refer to the tooth or teeth, neuropathic toothache, idiopathic toothache, that's the same as sorry, I remember. Persistent idiopathic dental alveolar pain, sorry. Idiopathic toothache and neurovascular toothache is the same as a migraine and TAX, trigeminal autonomic cephalalgia. Sinus pain refer to tooth. We have the lecture 2 days back. Cardiac pain refer to tooth. Psychogenic toothache or toothache of psychosocial origin. So I showed this figure 2 times. Myofascial pain refer to tooth. The patient have the dull, aching, and diffuse pain, worsened by mastication, head and neck movement, provocation of myofascial trigger points, and reproduction of the referral patterns. Diagnostic injection eliminates pain. Diagnostic injection to the muscle, not dental alveolar area. Diagnostic injection to the muscle reduce the pain. So again, I told you before, patient has a toothache, and you didn't see any tooth problem, the patient, and when you touch the palpate the muscle, master muscle temporalis, patient say, "Oh, I have toothache." So you can think about the myofascial toothache, and also that after if you inject the local anesthesia in the muscle, you numb the muscle. If patient the toothache reduced, you can diagnose that, oh, this is a toothache, non-odontogenic toothache came from the myofascial pain. So neuropathic toothache, the episodic paroxysms are, so because this is a neuropathic pain, paroxysms are provoked by relatively innocuous peripheral stimulation of a trigger zone and intraoral or extraoral sites, such as the buccal mucosa above the molars, the lips, molars, or lips, the chin, nares, and the nasolabial fold. Pain described as excruciating, electric-like, and brief. Local anesthesia with topical anesthetic administered the trigger zone intraoral reduce the episodes of paroxysmal pain, and it's an episodic neuropathic toothache. Also, that there is a continuous neuropathic toothache, continuous persistent pain, toothache-like, and associated symptoms, paresthesia may be reported. Continuous neuropathic pain may be accompanied by sensory abnormalities such as hypersensitivity and or allodynia. Do you remember allodynia? I will show you, I will tell you again. Usually, finger touch is not painful, but the patient has allodynia. show the say the pain with the finger touch. That is allodynia. And continuous pain that this and or periodontal tissues without objective physiological or radiological findings at site of pain and with an unknown etiology that lasts over 4 to 6 months. The most frequent somatosensory abnormality were somatosensory gain with regard to painful mechanical and cold stimuli and somatosensory loss with regard cold detection and mechanical detection. That is idiopathic toothache. But when you diagnose, you can, I will go back again. You can diagnose with this persistent idiopathic dental alveolar pain. And okay. And also neurovascular toothache, the migraine attacks and migraine spontaneous throbbing pain, I told you, made worse by physical activity, I told you, 4 to 72 hours, yes, nausea, vomiting, photophobia, phonophobia. And tax trigeminal autonomic cephalalgia, one of them is a cluster headache. Do you know the cluster headache? Usually male have this kind of the cluster headache, very severe. And that comes at nighttime and very, very severe. Episodic intense periorbital and maxillary pain lasting 15 to 180 minutes, 3 hours. This autonomic accompaniments of cluster headache include lacrimination, rhinorrhea, scleral injection, pupillary myosis, as seen in the Horner syndrome. There are no signs and symptoms between paroxysms. Although neurovascular toothache may be induced by histamines and or alcohol types. Chronic proximal hemicranius, CPH, acute episodic periorbital and maxillary pain associated with these autonomic features. The chronic proximal hemicranial, usually female has this kind of problem. All right. Sinus pain referred to toothache. Pain occurs in the maxillary molar teeth induced by cold stimulation or mastication, and dysesthesia arises with tooth clenching. Computed CT and pathological examination showing sinusitis or a malignant fibrous histiocytoma. So you can see the here inflammation with the CT. Also, we have the lecture, right? Sinus-induced toothache. So I don't need to tell you much, right? And cardiac pain referred to tooth. So far, nobody had a lecture this, right? Tight and burning aggravated by exercise, improvement with rest, bilateral symptoms, reduction pains observed following the administration of sublingual tablets of glycerol trinitrate, glycerin. Yeah. So if sometimes, not many cases, but patient comes dentist for the toothache, and the patient may have the cardiac problem. It's difficult to decide, but you need to call the ambulance. You need, because the patient may die in your clinic. There are several reports. Patients had a cardiac pain, cardiac toothache, and they had a severe problem after the dental treatment. So before the treatment, you need to call the ambulance if you feel something wrong. Usually, these patients had already cardiac problems, so you need to ask the patient the previous medical history carefully. Okay. And also the psychogenic toothache or toothache of psychosocial origin. An inconsistent site of pain in the anatomical innervation area, bilateral symptoms, continuous and persistent pain. This is a psychogenic toothache or toothache of psychosocial origin, but it's also difficult, very difficult, but you need to listen to the patient words carefully. It's okay? All right, so let's move to the case study. Do you remember the case? I will show again. Patient number 1, 39-year-old female patient. Chief complaint was left lower first molar toothache. And do you remember the present illness? Dental caries was found in number 19, the lower first molar, left lower first molar. Inner restoration has been done in left lower second molar. As number 18 showed percussion pain, the inlay was removed and the patient was relieved of the symptoms. In the next month, the patient had complained of spontaneous pain in number 19 and pulpectomy was done. However, the symptom was remained. Treatment for hypersensitivity on left lower area was done. Hypersensitivity treatment is we put some coating on the tooth, but the pain was still remained. Occlusal adjustment and occlusal appliance reduced her pain, but the pain was still remained. It's okay. More health history, medical history, metallurgy. I showed you yesterday, metallurgy to nickel, palladium, chrome. Dental history, nothing relevant. Psychosocial history, nothing relevant. Current symptoms, dull pain was on number 19, same as initial pain complaint. Tooth clenching or hard food induced the pain. Master muscle palpation induced the pain. Also, she had a headache, also the shoulder stiffness. So, interview of pain, roughly I tell you, left lower second molar, progress 1 year, dull pain, and pain intensity was 3 out of 10, and frequency several times a day, and duration several minutes, less than 1 hour. The clenching and hard food aggravate the pain. Aggravating factors are not touching the teeth. Associated symptoms are muscle pain, headache, shoulder stiffness. And dental X-ray showed, I showed you yesterday, but almost nothing, right? I don't think you see some problems with this X-ray. And the tender muscle, the other examination showed the tender muscle, temporalis posterior belly of digastric, trapezius, sternomastoid. Jaw movements were okay, no TMJ noise, no TMJ tenderness. Neurological examination, nothing relevant. So what's the diagnosis? Does anybody want to tell something? No? It's easy, huh?
MPDS, sir.
What?
MPDS.
Can you tell me again?
Myofascial pain dysfunction syndrome, sir.
Oh, yeah, you are right. Easy, huh? So international classification of orofacial pain, primary myofascial orofacial pain. So this patient fit this primary myofascial orofacial pain. So I told you many times, I showed you this slides many times. So myofascial pain induced toothache. Easy, huh? So diagnosis was a non-odontogenic toothache. Myofascial pain referred to tooth. That is the diagnosis in the first case number 1. It's okay. So patient number 2, 27-year-old female. Regarding the treatment management, I will tell you tomorrow. Chief complaint was case number 2, pain in the right master muscle which shoots up toward the cheek and forehead. Wisdom tooth extracted 1 year prior to the visit. Subsequent pain radiating to ear and chin. Eating exacerbated her pain. Medical doctor gave ibuprofen, NSAIDs, on the reasonable assumption that she was having an inflammatory response to the extractions. History of present illness. She returned 1 month later, indicating that the pain was getting worse. She was referred to the TMD specialist for evaluation. She was treated for TMJ problem. Patient became symptom-free after that. Patient returned to medical doctor 5 months later, reporting the pain had returned. Medical doctor recommended that dentist make a splint. patient patient returned home and began having pain again and came to Orofacial Pain Clinic. So she was taking ibuprofen and she reports social things. She was being easily stressed out with minor things. She's jogging every morning to prepare for marathon. And she drinks 1 cup a day, no alcohol, no smoking. Pain right cheek area, same the initial pain complaint. Pain is continuous with occasional electric shocks, but varies intensity without pattern. Pain exacerbated by brushing her teeth, washing her face, pushing on teeth, talking, licking lips, and touching the right face or right palate. The other pain was described as soreness near right TMJ and along the angle of the mandible. Pain occasionally awakens her. So means she woke up with the pain. So she has 2 types of pain. I showed you yesterday. Continuous pain and electric shock-like pain. Continuous pain is the right cheek area, 1 year, soreness. Pain intensity 2 out of 10, frequency continuous, duration continuous, and nothing particular. And the electric shock pain, right cheek area, approx 1 year. Occasional electric shocks, but varies intensity without pattern. Intensity is 8 out of 10, and frequency several times a day, and the duration several seconds. Aggravating factor: brushing her teeth, washing her face, pushing on teeth, talking, licking lips, and touching the right face or right palate. And the behaviors: when she has a pain, she cannot do anything. She couldn't do anything. That is an electric shock pain. The other examination: jaw movement is okay, no TMJ noise, no TMJ tenderness, no head and neck muscle tenderness. Neurological examination, we did not. So do you remember the cranial nerve 1, 2, 3, like 5 or like that? And so no problem. TMJ X-ray, nothing relevant. So diagnosis. Actually, Dr. Sajjad yesterday said trigeminal neuralgia, right? Yeah. So trigeminal neuralgia, but there is 2 types of pain, right? So trigeminal neuralgia, I showed you yesterday, today, but she had a continuous pain also. But electric shock pain, the trigeminal neuralgia, continuous pain, maybe she had a continuous 2 types of the trigeminal neuralgia pain. But so she's young, right? Usually, do you remember her age? 27, right? So usually, trigeminal neuralgia patients are not young, around 60 or 70, at least 50, 40 years old. 27 is too young to have the trigeminal neuralgia. So we sent the MRI. So what do you see in the MRI? Do you see something? Do you see the eye, spinal cord, bones? You understand? I think you find the problem here, right? And also you see the clearly. So, adjusted diagnosis. She is 2 centimeter acoustic neuroma, schwannoma or meningioma, we can call, in the right cerebral pointing angle. So here, international classification of orofacial pain and orofacial pain attributed to lesion or disease of the cranial nerves. 4.1.2, 4.1, pain attributed to lesion or disease of the trigeminal nerve. 4.1.2, secondary trigeminal neuralgia. 4.1.2.2, trigeminal neuralgia attributed to space occupying region. So she has this. Oh, sorry. So I will tell you the treatment, but easy, huh? Yeah, neurosurgeon. We can say neurosurgeon. So regarding diagnosis, that's it. Thank you. If you have a question, ask me anytime. Oh, Dr. Abhinab. Sorry, Abhinab.
Yeah. Thank you, Professor Masuka, for the enlightening lecture on the orofacial pain diagnosis. So over to the audience for any question to Professor Masuka.
It's okay.
Hello, sir.
Yes.
Audible?
Mm-hmm.
I have a question, sir. So, what is how can we differentiate between the MPDS, that is myofascial pain dysfunction syndrome, and other kind of myopathies that can occur, like injury to the muscle or inflammatory myopathies?
Can you ask me again? Sorry.
Could you ask question and put your other device off mode? It's a two voices coming and it's mixing.
Okay, sir. How can we differentiate? How can we differentiate between the MPDS, that is myofascial pain dysfunction syndrome, and other kind of myopathies like injury to the muscle or inflammatory myopathies?
Myofascial, we need to, you want to know the differentiation between the myofascial pain and the other muscle problem, you said? What's the other muscle problem?
Yes, sir. Yes, sir. Like, sir, if there is any injury to, sir, specific muscular injuries, like, sir, if there is.
Oh, injury. Injury.
Yes.
Oh, yeah. Sorry. Did you say the primary myofascial pain and secondary myofascial pain?
Yes, I think so.
Yes, sir.
Yeah.
Okay, okay. So sorry. Where? So can I show the slide again?
Yes. Yes,
Yeah,
Professor.
I'm doing something. Diagnosis. Can you see the slides?
Yeah, they are visible.
Okay. I can make bigger. So secondary myofascial or facial pain, the here underlying disorder known to be caused myofascial pain has been diagnosed. So that is a difference. And also evidence causation has been demonstrated. So actually, it's very difficult, huh? It's not easy to diagnose this is the underlying disorder or injury. But you can listen the patient carefully. Maybe you will find that before the injury or before some problem, if patient did not have any myofascial pain, and after the only injury, if patient has a problem, we can diagnose the secondary myofascial or facial pain. Is it okay? But however, if patient has a car accident, if patient has a litigation, maybe the patient does not tell you the truth. So it's very difficult if patient has a kind of the car accident. It's okay?
Okay, sir. Yes, sir. Thank you so much.
Thank you.
Hello, sir. I have a question.
Yes, yes.
So,
go ahead.
What is the presentation of a patient with psychogenic toothache? I mean, how does the patient present with psychogenic toothache? What is the clinical situation there?
Good question. I will show tomorrow, but the psychogenic pain is difficult to diagnose. And so if yeah, but you can feel the something wrong. The patient stories, something wrong you can find. Also that you can see the patient face and voice. And so one thing is you cannot you cannot diagnose easily if patient has a psychogenic or psychosocial problem. Do you, what can I say? But where the sorry, just a moment. I will check my slides. I will check my management. Do you have, can we have time?
You can take your time.
Thank you. Oh no, I don't have. So regarding the diagnosis, maybe of course you need to ask the patient carefully. Maybe patient has been to the psychiatric doctor already, and also the patient say something wrong. Something wrong means not something you don't understand. So in this case, you can what can I say? You can doubt. She's talking. She's saying something wrong, like that. Then you need to you need to ask. You need to listen carefully with the patient's story. Also, in the psychogenic psychiatric diagnosis book, there is in the world DSM-5 or DSM. I think DSM-5 is the current most current one. Then you can read that the patient problem is yeah. So again, it's very difficult. Is it okay? Do you understand?
I think it's okay.
Okay, thank you.
So, are there any more questions? I think we are done with the questions. So we'll start with the lecture 5 of today's series, the last lecture, occlusion and orofacial pain, diagnosis and management of occlusal dysesthesia. Dental occlusion may be related in some orofacial pain condition like dental pain, myofascial, orofacial pain, TMJ pain, and tension type orofacial pain. Professor Yoshijo Matsuka in this lecture will discuss about occlusion and orofacial pain, an effect of occlusal adjustment, diagnosis and management of occlusal dysesthesia, and management of orofacial pain. So over to Professor Matsuka for the next lecture.
Thank you, Dr. Abhinav. And so I will talk about occlusion and orofacial pain, and also I will talk about diagnosis and management of occlusal dysesthesia later. So this is again, this picture is the Tokushima. Tokushima has some falls, right? Beautiful falls. All right. So I showed you many times international classification of orofacial pain, and regarding with this classification, which problem had related to occlusion? Which problem is related to occlusion? I thought I wondered. So maybe sorry.
Surgery.
Dental pain is related to occlusion, probably. And myofascial orofacial pain and also temporomandibular joint pain may be related with occlusion. This is questionable. Number 2 and 3 questionable. And also tension type orofacial pain may be related with occlusion. All right. So I will tell you something. And in the number 1.1 dental pain, there is a classification here. Dental pain attributed to hyperocclusion or hyperarticulation following dental restorative procedure. So there is one classification. So if patient has a high inlay or high crown, and patient, after that patient complain the dental pain. So maybe that is a pulpal pain attributed to hyperocclusion or hyperarticulation following dental restorative procedure. But you can read the diagnostic criteria of this also. So please check it. And then 1.2.1.1.1 periodontal pain attributed to hyperocclusion or hyperarticulation. So there is a one diagnosis. So these things may be related with the occlusion and the orofacial pain. Also, pathogenesis. Think about pathogenesis. Trigeminal result of demyelination, the loss of the insulating myelin sheath that separates individual nerve fibers, the demyelination was to spontaneous ectopic nerve firing. Maybe it's not, maybe not related with occlusion, huh? Migraine, activation of the receptors of the dura and associated vessels, activation of that blah, blah, blah. Migraine also may not be related with occlusion. Tension type headache. Tension type headache is directly related to muscle tension. So yeah, maybe if dentist give the high crown or high inlay, maybe the muscle tension is increased. Maybe tension type is related. We can think. And occlusion TMD, there is a review in 2017 code rate. So this review is good, very nice. So I introduced this review. The role of occlusion as an etiologic factor in temporomandibular dysfunction is a controversial subject. It's controversial. From long time, the researcher discussed many times. And many dentists believe that the occlusal discrepancies are an important etiologic factor in TMD, many dentists. And the belief is reinforced by successful results following occlusal treatment. So that some dentists did a dental occlusal treatment and the patient said, oh, my muscle pain reduced. Dentist had this kind of results. However, other clinicians claim equal success following the use of non-occlusal treatments. Yeah, this code rate reported. Studies on the role of the occlusal factors in TMD fall broadly into 4 categories: experimental, electromyographic, epidemiologic, and clinical. The evidence contained in these studies is often conflicting, and some of the studies have serious shortcomings. For example, had occlusal factors not been dismissed as unimportant in some studies, the result could have been interpreted differently, they said. And experimental. So I will show the experimental and electromyographic, epidemiologic, and clinical. Experimental studies in which various occlusal interference were incorporated. The instance of dysfunction after 7 days is reported in the last column. So this very old studies, 76. Were you married? I don't know why you get bored, but are you in the world? And the study, so this is a patient number. And also that they did a posterior interference, 0.5 millimeter high inlay or amalgam or lateral deflective contact or crown with 0.5 to 1 millimeter shift anterior to right lateral from central regulation, blah, blah, blah. So subjects with dysfunction after 7 days, this study, 8 out of 7 patients had dysfunction. This study, 4 patients has dysfunction. This study, 0. So it's table 1. This previous table shows the incidence of TMD as determined by muscular and or temporomandibular joint pain 1 week after placement of various interferences in small samples of subjects, they said. Surprisingly, the incidence of dysfunction varied from high to low in these 5 studies. Two glaring weaknesses of these studies are the extremely small sample sizes and short periods over which symptoms were monitored. Long-term follow-ups would have been more useful. The outcome of this type of the experiment is most likely determined by the subject's neuromuscular adaptive capacity, or in other words, the subject's ability to absorb an interference without producing significant degrees of muscular incoordination, hyperactivity, or parafunction. And so this is the experimental studies result. So they said, it's not clear. We don't know. Electromyography. Studies comparing dysfunctional and non-dysfunctional subjects found that most TMD patients showed increased and uncoordinated electromyographic activity of the master muscles. But it's old studies also. Studies also found that in many cases that EMG silent period is that the temporary pause in ongoing EMG activity of jaw closing muscles during maximum clench is also longer in TMD, which implies a possible neuromuscular difference between TMD and non-TMD subjects. But it's not new study, right? Finally, studies have found that brachists with TMD showed a decrease in both dural DMG hyperactivity and in coordination following occlusal adjustment. So the electromyographic studies show that maybe occlusion and TMDs are related. A number of epidemiologic study. A number of occlusal factors have been linked with TMD. These include loss of vertical dimension, Costens study, 1934, a number of contacting teeth, and orthodontic malocclusion, specifically crossbite, anterior open bite, and deep bite, occlusal interference, and deflective contacts. However, the link between occlusal factors which have been implicated in producing TMD and dysfunction is not always evident from the literature. There has been much speculation on the way in which occlusal factors may produce dysfunction. It can be understood that posterior tooth loss, particularly in the presence of parafunction, can predispose to overloading the TMJ. The mode of action of occlusal interference deflective contacts is more difficult to determine. So difficult to determine, they said. However, there are 2 principal theories. One, the first theory is that occlusal factors induce the subject to parafunction. 2, the second theory is that the functional movements are adversely affected when the subject subconsciously avoids the aberrant tooth contact. This is known as aberrant function. Both theories acknowledge that psychic stress may combine with an unfavorable occlusion to produce dysfunction. Parafunction and aberrant function may produce muscular hyperactivity and incoordination. Balancing interferences may act as pivots that produce adverse leverage. Thus, overloading the TMJ components is in compression or tension, they reported. Okay, that is an epidemiologic study. So still not clear, huh? Clinical occlusal therapy. So over the last 5 decades, occlusal therapy has included reconstruction and occlusal adjustment and to enhance the functional relationship. The response of TMD patients to occlusal therapy has been assessed by both subjectively by patient reports of pain remission and objectively utilizing EMG data, the Helcom dysfunction index, pantographic tracing, condyle radiography, and also sonic recording is occlusal sounds, and three-dimensional condyle position registrations. And Ramfield is a famous study. The famous researcher used the electromyography to evaluate the effects of occlusal adjustment on population of 35 brackets with symptoms of TMD. Excessive EMG activity was normalized after adjustment, and all symptoms were alleviated. This study is often cited in support of occlusal adjustment as an effective mode of therapy. However, they wrote, the study has several methodological problems. No controls. Also, the long-term follow-up was not reported, and the study has not been duplicated. Magnusson and Carlson, also they are famous guys, utilized the Helcom dysfunction index to monitor the effect of further occlusal adjustment in patients who had residual signs and symptoms of TMD 2 to 5 years after initial occlusal adjustment. The treatment was found to be effective in removing the pre-adjustment signs and the symptoms. Thus, occlusal adjustment studies suggest that occlusal adjustment can reduce the clinical signs of TMD. However, the problem with studies of this type that they lack controls. They don't have controls. The treatment is not randomly allocated, not randomly. And the occlusal adjustment method is sometimes questionable, they said. So why the epidemiological evidence implicating occlusal as a causative factor in TMD is weak? No clearly defined link has been determined from the epidemiological literature relating occlusal factors or condyle positions and TMD. How can this be? There may, in truth, be no link because the dysfunction may arise as a result of other factors. However, other reasons must be considered. The literature relating occlusal factors and condyle position to TMD must be assessed in the context of the clinical problems that affect this possible relationship. These problems may be summarized as follows. So summarization. Number one, TMD is multifactorial and the etiology and extent of TMD are difficult to diagnose precisely. Number two, the occlusal and condyle position evaluations that form the basis of these studies may have been inadequate. The identification and full extent of deflective occlusal contacts in dysfunctional subjects may be hidden by guarding of neuromuscular. Neuromuscular adaptive capacity. Occlusal factors may cause little or no dysfunction because they lie within the subject's neuromuscular adaptive capacity. The neuromuscular adaptive capacity may be lowered by stress and emotional problems. The role of occlusion in development of signs and symptoms of TMD continues to be source of controversy. So still controversy, nobody found. There has even been a movement within this dentistry over the past few decades to minimize the role of occlusion in TMD and to de-emphasize the study of occlusion in dental education. However, this review of the current literature specifies that despite the fact that the etiology of TMD is probably multifactorial, completely discounting the role of occlusion may be an inappropriate interpretation of published data. They concluded. Also, so American Academy of Orofacial Pain guideline reported like this: occlusal adjustment was at one time considered beneficial for TMDs, and occlusal interference were implicated in the etiology of TMDs. However, there is not evidence for which type of occlusal interference, if any, might impede jaw function or play an etiologic role in the development of TMDs. a Cochrane database review and several other systemic reviews of RCTs, randomized control trials, showed that there was not enough evidence that occlusal adjustments are useful to prevent TMDs. Wow. Restorative or prosthodontic dental care should never be primary treatment option for TMDs. Orthodontic treatment is often the treatment of choice when major occlusal alternations are considered to be dentally advantageous. A review of the literature concluded that the best on the available evidence, orthodontic treatment neither causes nor cures TMDs. That's it. So yeah, it's okay. So still occlusion and orofacial pain is questionable. Also in the occlusion and TMDs are still questionable. It's okay. All right. So move to the occlusal dysphagia. Do you know the occlusal dysphagia? So here, this is the patient. The occlusal discomfort started after the orthodontic treatment, and the patient had shoulder stiffness and headache. And the dental occlusion is fine, of course. The criteria for dental occlusion is difficult, right? Do you have the good criteria for the occlusion, dental occlusion? The Japanese Prosthodontic Society has a guideline, but it may not be related to the occlusal treatment. So here, this is the normal occlusal contacts. The Japanese Prosthodontic Association reported. Intercuspal position is condyle stable position. All right. What do you know the condyle stable position? Condyle is stable in the fossa. That is a condyle stable position. Okay. And number two, there is no premature contact during mouth closing and intercuspal position is stable. Several teeth contact same time during the mouth closing. So like this, there is no difference between right and left. No right and left difference. There are more than 4 contact points in one side. So most of the molar are touched. There is no difference on the contact points between right and heavy clenching. So right clenching and heavy clenching, no difference. Occlusal force should be right force minus left force divided by right force plus left force times 100 is around 9%. So it means that no difference between right and left. There is no cuspal interference during the lateral movement, and there is adequate tooth guide. Canine or canine premolar should contact on working side, like this. No or weak contacts on non-working side. No contact in non-working side or weak contacts. So contralateral side is no contact, almost no contact. It is better that mandible it is better that mandible move forward in lateral movements, not backward. So when the lateral movement, when the patient do the lateral movement, move forward, not backward. You understand? Do you think it's good guideline? Good. Yeah, it's good, but so what? Yeah, we can find a good contact person, but bad contact person, even though some people do not have teeth, right? Even in India, I think you have many persons who do not have teeth. Also in Japan also, but they don't have the problem, any problem. They don't have the pain. They can chew anything, even though they don't have tooth, right? So it's normal. It's good guideline, but we can say, so what? I can say, because I doubt everything. So the other view on normal occlusal position that Fukushima reported in Japan also. So she differentiates 3 patterns: TMJ form, no change, changes, but some change but stable, and some change and non-stable TMJ form, and condylar position, condylar stable position, and adaptive centric position, and occlusal position, habitual position, habitual position, habitual position. So it's the same. This one line like this, like this. So what can, I want to say that condylar position and form can be adapted by occlusion. So do you remember the first thing, condylar stable position, the Japanese Prosthodontic Association guideline said, condylar stable position, but condylar position and shape, form can be adapted by occlusion. So we don't know what is good. So I can say try not, also Dr. Fukushima said, try not to change the current occlusal position if it is okay. That is a occlusion. But even though there is a good occlusion, patient complain the occlusal problem. That's the occlusal discomfort syndrome. So occlusal discomfort syndrome, narrow sense. An idiopathic syndrome of pathology characterized by discomfort related to occlusion, but having no relation to dental occlusion. So how patient occlusion is very good, but patient complain the occlusion is not comfortable. This is the same pathology associated with the occlusal dysphagia defined by Clark and Simon. The Dr. Clark and Dr. Simon said occlusal dysphagia like this are persistent more than 6 months, uncomfortable, bad sensation, which does not correspond to any physical alteration related to occlusion, pulp, periodontium, muscle, or temporomandibular joint, and cause significant functional impairment. That is the occlusal dysphagia. In the other words, the patient complains of occlusal discomfort, but dentist could not find any problem. Occlusion is fine. That is occlusal dysphagia or occlusal discomfort syndrome, narrow sense. In Japan, we call occlusal discomfort syndrome, but in the world, occlusal dysphagia is famous, more famous. It's okay. And so Dr. Tamaki reported occlusal discomfort syndrome or occlusal dysphagia patient, the patient characteristic. I think, I believe you saw many patients in your clinic. Patients do not adapt to changes in their occlusal contacts and jaw relations brought about by subtle changes in occlusion after dental treatment. Patients perceive occlusal contact as incorrect or with extreme sensitivity, even though their occlusion is normal. I think you saw many patients. The syndrome may occur without any occlusal influencing treatment. Without treatment, the syndrome comes. Patients believe that systemic body symptoms are related to the dental occlusion. So patients complain that, oh, my occlusion is not good, and I have backache, and I have stomachache or something. Patient reported. Patients repeatedly visit many dental or medical offices and claim that they have been experiencing psychosocial and occupational disadvantages. Yeah, patients do. And patients frequently verify their own occlusion and or jaw relations. So they're checking the occlusion. Oh, my occlusion is not good. The patient said. Number 7, patients fully believe that their occlusion is abnormal. Yeah, even though dentist said, oh, your occlusion is fine, dental occlusion is fine, but patients believe occlusion is abnormal, even though no objective occlusal abnormalities are apparent. Patients bring devices, provisional crowns or something, many, provided during previous treatment. Also, they bring some previous cast model also when they visit the new dental offices. Patients usually also the long letters notes. They made the reports and their own drawings when they visit new dental offices. Patients usually refuse to visit psychiatrists, even though psychiatric disorder disease are recognized. Patients usually refused medications. That is the patient characteristics. And I did a paper search recently, maybe in February I did, and with the PubMed, I entered occlusal dysesthesia or phantom bite. The other name is a phantom bite, occlusal dysesthesia, and I found the 30, and I found the 111 papers, and with the title search, I selected the 33 publications, and 16 came from Japan, Japanese Institute. And there are many papers from USA in the early stage. So half of them are from Japan. So do you think Japanese have more occlusal dysesthesia? I hope, I believe you Indian dentists have these kind of occlusal dysesthesia patients. Most of them reported that occlusal dysesthesia related with psychosomatic factors. So in the 33 papers, most of them that said occlusal dysesthesia is related with psychosomatic factors. So Dr. Kuboki reported this figure. So associated cause of pathophysiology of the syndrome, occlusal dysesthesia syndrome, clear occlusal change. If patient have the clear occlusal, so clear occlusal change mean why do we have patient have the clear occlusal change? Acute occlusal change or chronic occlusal change. Acute occlusal change came from the dental caries, tooth missing, periodontal disease, or muscle tonus and condylar fracture, luxation, TMJ problem. Chronic occlusal change came from the tooth movement, tumor cyst, occlusal attachment, or dystonia, or disc displacement, osteoarthritis, rheumatoid arthritis, osteochondroma. So no clear occlusal change, even though, so of course, this clear occlusal change patient complain how their occlusion is not good. And also dentists can realize, oh, you have bad occlusion. But this one, no clear occlusal change, but patient complain the occlusal problem, occlusal discomfort. So peripheral problem with low occlusal force, maybe myasthenia gravis, sorry, my pronunciation bad, muscular relaxance. So in this case, patient complain the occlusal problem, and also the no clear occlusal change. And also if patient has CNS problem, central nervous system problem, brain infarction, brain tumor, multiple sclerosis, Parkinson's disease, patient may complain that occlusal problem. And purple one is our this lecture target, occlusal dysesthesia, abnormal signal transmission, somatization, schizophrenia, delusional disorder. So psychosomatic problem and abnormal signal transmission, neurological problem. So associated cause of pathology of the occlusal dysesthesia. One is the abnormal signal transmission and or data information processing from the peripheral to the central nervous system. Number two is psychiatric disorders or disease. So let's say abnormal signal transmission. There may be distortion of input from peripheral sensory receptors in the periodontal ligament, TMJ, and masticative muscles, resulting in disturbance in signal transmission from peripheral to higher centers, maybe. And also there are several papers, sorry, they are from Japan, but they reported these things. Psychiatric disorders, somatization. I told you 2 days back. Somatization due to psychiatric disorders, somatoform mood, anxiety, personality, paranoid disorders, and schizophrenia are considered primary causes. All right. So abnormal signal transmission, I will talk about first. Neurosensitization after clenching the teeth. So if patient clenching the teeth a lot, the neurosensitization, neural information go to the brain and the neurosensitization in the central part occur. And occlusal dysesthesia comes in busy time or after mental stress. In these patients, occlusal dysesthesia feeling comes in the busy days. Upper and lower teeth touch in the resting position. So when we say to the patient, relax your mouth, but patient upper teeth and lower teeth are touching continuously. And buccal mucosa and tongue impression. Do you understand this? So you can see the shape of the teeth in the buccal mucosa or tongue. So tongue is not like this, round, like more star shape. Do you understand? So after tooth clenching, sensitization of mechanoreceptor, of course, touch sensation transmission in A beta fiber, and go through the trigeminal ganglia and spinal cord and feel discomfort in the brain cortex. So again, same pain transmission, but different nerves. So if you don't have the brain, you don't have the occlusal dysesthesia. Yes, of course. So one of the data is tooth stimulation and brain function. So the Dr. Trusson stimulate the tooth and check the MRI, or not MRI, brain function MRI. They found that some part of the brain firing. So this data shows that if you push the teeth continuously, some part of the brain continuously were acting. All right. So I have one case. This patient, a 60-year-old female, chief complains that occlusion is strange. She said, occlusion is strange. I cannot chew because the bridge was high. I will tell you later. The bridge contacts during the resting time, she said. History of present illness. After setting the bridge to the lower left 1 year before the first visit, she began to become aware of toothache, occlusal discomfort, stiffness of the neck and the shoulders, and the heaviness of the head. Occlusal adjustment was repeated in the previous dentist, but uncomfortable feeling was not improved. She doubted the dentist who set the bridge. Wow. Present illness, tenderness on left master, left digastric, and left trapezius muscles. So this is a bridge. She had this bridge. And she said this bridge was high and she cannot chew, she said. And the previous dentist did the occlusal adjustment, but same, she said. And I saw the occlusion. Occlusion is very fine, no problem. She didn't have any problem. So what do you think about? So I took picture. So do you see something? So this is the mark. What did I say? Sorry. No, I didn't write. Oh, buccal mucosa and tongue impression. I don't know it's good English or not. So you see something right here. So she clenches the teeth a lot. So diagnosis, the bridge setting triggered daytime tooth clenching, and the tooth clenching induced toothache and occlusal discomfort. Management, what I did, I made a study model and explained that the occlusion was not bad. She understood. She's okay. She's not psychiatric patient. I instructed to avoid contact of the upper and lower teeth at rest and opening stretch and do the like this. I told her that doing the opening stretch. And sorry, sprint is L, right? I made sprint, well, she used at night. Even without removing the bridge, the symptoms, toothache, occlusal discomfort, stiffness of neck and shoulders or heaviness of the head disappeared. It's good, huh? I like it. However, she wanted to remove that bridge. She wanted me to make a new bridge because she hated the previous dentist. So I made a new bridge, same as previous shape. But she's okay. She was okay. So next thing is the psychiatric disorders, disease somatization. Somatization, I told you before, 2 days back. Somatization is a physical condition, complaint, and symptoms cannot be explained well, even if appropriate tests were performed. The occlusal discomfort can be one of the somatization symptoms. So the somatization, patient complained something. Occlusal discomfort is also, patient say, oh, my occlusion is not good, but we couldn't find, dentist couldn't find any problems of occlusion. That is one of the somatization. So principle, if you see a patient with symptoms of somatization, do not do anything. Don't do anything. The psychiatric doctor told me, never perform irreversible procedure or invasive procedure. So don't do the occlusal adjustment. Avoid excessive thinking. Avoid excessive thinking. You are thinking that I must cure all complaints of the patient, or I can heal the symptoms that the previous dentist could not do. I'm good. I can do it. Don't think about it. Patient presenting with somatization symptoms, consult a psychiatrist. Yeah, we can consult a psychiatrist. The psychiatric doctor also told me the dentist or surgeon think they can do by themselves, but the internal medicine doctor think previous doctor couldn't cure, so I couldn't cure. That is an internal medicine thinking way. So don't think, avoid excessive thinking. Okay, dealing with the patient with somatization symptoms. If it is important to send the patient to psychiatric doctor. However, many psychiatric doctors do not know the oral disease, of course. If the patient complains oral problems, the psychiatric doctor sends back the patient quickly to you, very quick. Oh, this is a oral problem, so go to the dentist. So you need to know something regarding the somatization. Again, somatization symptoms come from major depressive disorder or somatoform disorder, somatic symptom disorder, or other psychiatric disorder. So somatoform disorder, somatic symptom disorder, this one, center one. Any mental disorder which manifests as physical symptoms that suggest illness or injury, but which cannot be explained fully by a general medical condition or by the direct effect of a substance and are not attributable to another mental disorder, or panic disorder, etc. So DSM-5, the classification of the psychiatric disease, somatoform disorder include conversion disorder, somatization disorder, hypochondriasis, body dysmorphic disorder, pain disorder, fasciitis disorder, illness, anxiety disorder. So to this lecture, I'm talking about the occlusal discomfort, but also the somatoform disorder patient complain the pain a lot. So you need to know also. Somatization disorder, a mental disorder characterized by recurring, multiple, and clinically significant complaints about somatic symptoms. A history of somatic complaints over several years, starting prior to the age of 30. Such symptoms cannot be fully explained by a general medical condition or substance use. Somatization disorder patient can have physical disorder. So yeah, of course, even they have the somatization disorder, these patients can have the tooth caries, of course, muscle problem also. So be careful. You need to separate. Management of somatization disorder. Now the drugs or psychotherapy has clear effect. Wow. Primary care physician. Primary care physician means, in this case, dentist, you, becomes primary doctor. Ooh. Regular consult. So you need to take care. Means psychiatric doctor do not want to take care because they don't have the good drugs. It may be once every 4 to 6 weeks, short period of time is okay. Consider that patient complaints as a kind of emotional communication. Yeah. And do not get caught by the patient complaint itself, and do not miss the physical illness. So don't much be worried, but don't miss the caries or dental problem or facial problem. In some patients, the goal is to make relationship that can be introduced to psychiatric doctor at any time. That is the goal. Delusion. So other psychiatric disorder here, delusion. Of course, you know, right? Delusion. Mistaken belief that is held with strong conviction, even in the presence of superior evidence to the contrary. Example of the delusion in dentistry. I have heard many times. Embedded transmitter in a metal crown. Have you ever heard? Or GPS is in the metal crown. A balloon comes out from my mouth. Thread comes out from the mouth. Teeth are soft like rubber. Have you ever heard? I heard many times these complaints. And psychiatric disorders with delusion. Schizophrenia, delusional disorder, mood disorder, bipolar disorder, major depression, personality disorder, dementia. So in Japan, the people are old. So, you know, average age, the 89, lady can survive, average is 89, guys 82. So many old people in Japan. So we have many dementia patients. So we have in Japan many psychiatric disorder, many patients complain that delusion in Japan. But in India, soon you have the same thing. Management for delusional disorder, treatment with antipsychotics. Yeah, we can give the antipsychotics, not dementia, only delusion, only delusional disorder. But again, dementia patient, we don't have the good medicine. So yeah, so it's a problem. However, if antipsychotic works, however, since patients do not have consciousness of disease, compliance for the taking the medication is bad. So prognosis is poor. So patients do not want to take medication, antipsychotic medication for a long time, because they don't think they have the psychiatric problem. So they stop the medication. So we can say prognosis is poor. So to prevent occlusal dysphagia after dental treatment, so we want to prevent, right? So listen to the occlusal dysphagia patients. When I listen to the occlusal dysphagia patient said, after dental treatment, the tooth is continuously touching and the problems happen. Usually said. So usually people said the previous dentist are not good. Yeah, patient say like that. So means the patient may be clenching the tooth with psychological problem, without psychological problem. So to prevent occlusal dysesthesia after dental treatment, build a good relationship with patient. So after the good relation, you can do that. You can start the treatment. Before the good relation, don't do anything. Do not do prosthodontic treatment on the first day. Of course not. First day, you shouldn't do any prosthodontic treatment. Discuss well, talk well. Do not emphasize occlusal contacts. Oh, your occlusion is not good, so that's why you have the headache. Don't say like that, right? Do not emphasize occlusal contacts. Do occlusal adjustment with the prosthesis well. So when you make the bridge or crown, the occlusal adjustment before the setting, occlusal adjustment you need to do carefully. And also after the setting, you need to check the occlusion well. And consider wearing splint at night. So these patients, you can give the splint anytime, but only nighttime only. Pay attention to patients with psychological problems. Pay attention to patients with psychological problems. So you know that this patient may have the psychological problem. You can feel, you can smell, the smell is like that. Smell is like this. So if you feel the patient has psychological problems, you need to pay attention. All right, that's it. Thank you. If you have question, ask me.
Thank you so much for an enlightening lecture. Sir, threw light on a very important topic. I'm sure the participants have gained a lot and will be able to apply the knowledge clinically. Now, I would call upon the participants to ask the questions.
Dr. Abuhina changed the girl?
Yes, sir. Now I am your coordinator.
Sorry. It's okay.
Any questions?
No.
Then
so we should think that the occlusal derangement is not responsible for TMD or any kind of pain problem.
Good question. Yeah, in the world, maybe in the United States or Europe, they think occlusion is not related with orofacial pain much. But in the dental problems, also but the toothache is also the orofacial pain, one of the orofacial pain. So toothache is sometimes comes from the occlusal problem. That's it. The other thing, myofascial pain or neuralgia or TMJ problem, it's a controversial. They don't have the good conclusion so far. Even in United States, they are fighting, still fighting.
So, one more thing. We see TMD, like painful TMD, most commonly in young age group, like 45 to 50 years age group. We have many edentulous patients, like patient without teeth in a relatively young age. As I saw in Japan, even 80 years old have some teeth, but here it's a different situation. So I saw that, like it's my own experience, that in edentulous patients never came with TMD, painful TMD problem. So is it so that I feel like, is there any relationship or not? Can we say like edentulous patients never have painful TMD?
Yeah, in Japan, edentulous patients have TMD problems sometimes in Japan.
But there are not so many edentulous patients, maybe 1 or 2 in 1,000.
Yeah, but yeah, you are right. But yeah, you are right. But some patients have the teeth, only few teeth, right? Then occlusion, they don't have occlusion, but they have some TMD problems. Some patients. But okay, maybe good question. I don't know the answer. Where maybe you can do research.
So there is a question from a participant. It is, does CBT cognitive behavioral therapy work out for these patients? Basically, what's the treatment for occlusal dysesthesia?
What's the treatment for occlusal dysesthesia? What's the treatment of? Oh, good questions. Yes, cognitive behavior therapy. Yeah, it's good therapy. I think I agree with you. And also the occlusal dysesthesia patient. One of them is if you can differentiate what kind of problem that occlusal dysesthesia patient have. Maybe if patient have too much occlusal contact, clenching. If the patient is clenching, you can tell them that don't clench the teeth and give the splint, and also the if severe bruxism patient, you can give the muscle relaxants, and also that is the if patient do the clenching, and if patient have the psychological or psychiatric problem, you need to not to real diagnose, but you can think about what kind of problem, and you can talk the psychiatric doctor carefully. And you need to write to the psychiatric doctor, this patient has the occlusal discomfort, but patient doesn't have any occlusal problem, dental problem, and maybe the psychological or psychiatric problem patient have. You need to tell the psychiatric doctor carefully, so the psychiatric doctor will see the patient well. If you have the good friend, psychiatric doctor friend, it's the best. It's okay.
Thank you, sir, for the explanation.
No, sir. I have a question, sir. Sir, how do we know which occlusion therapy has to be used for the particular patient? Like, where do we increase the vertical dimension, and where do we go for ortho treatment?
Sorry, can you ask me again?
For example, there is a occlusal derangement in a patient. So how do we decide that which occlusal therapy are we going to give? Like we increase the vertical dimension, and also are we refer the patient to the ortho treatment?
So I couldn't catch the question. Sorry, can somebody say again? So, Dr. Abhinab. No, it's not Abhinab.
Abhinav, yeah. Sir, actually, she's asking, how do we decide what treatment we have to give to the patient? Whether do we have to increase the vertical dimension, or do we have to refer the patient for ortho treatment?
Oh, so can you repeat again first?
Okay, sir, I will repeat again. Okay, how do we know which occlusal therapy has to be used for the particular patient? Like in whether we have to go for in TMD cases, whether we go for increase in vertical dimension or we go for orthodontic treatment.
Okay, thank you. Good questions. Thank you. And usually we don't do the occlusal therapy for the TMD patients or orofacial pain patients. We will do the splint therapy. That's it. So we don't change the occlusion for the TMD patients or orofacial pain patients. So if patient have the occlusal problem, not related with the TMD, patient can go to the orthodontic treatment or prosthodontic treatment, but we don't do the TMD. We don't actually. Most of the Japanese dentists do not do the. Also, the American or European, they don't do the occlusal treatment for the TMD problems or facial pain problems.
Okay, thank you, sir. Thank you, sir.
And just in case, like, for example, somebody came with a painful TMD and you gave him diagnostic splint and the patient improved. And you asked him, okay, you can wean off your splint now. There's no need for splint. And then again, he has problem. So what do you think should be the line of management in such a case?
So if the splint works, we will ask the, we most of us mean the American or Japanese or European, tell the patient use the splint continuously. And some reports said when patient use the splint continuously, sometimes they do the clenching on the splint. So the current report said use the several days. I mean that if patient use the first days, use splint first day or several days and stop the splint several days and again use the splint several days. That is a good way to reduce the clenching with the splint.
So maximum, how long can we give the splint?
My experience, some patients use several years.
Okay. And one more thing is that I read papers, like they said, like these delusional disorders and whatever psychiatric problems, schizophrenia, Alzheimer's disease, dementia. So it has a relationship with masticatory. So if we improve the mastication ability, it can have a positive effect. No, it cannot change the disease, but it can have a positive effect on these conditions. So are there any, like I read only in research, like preclinical research, they made models of Alzheimer's and then they improved the masticatory function and then they saw it has a positive effect. So what is your, what do you think about it?
Yeah, I agree with the report. So if the patient has a occlusal problem, occlusal comfort problem, and if patient has a psychiatric problem, and if patient take the psychiatric medicine, they have good result with also occlusal problem. So I saw many patients, but again, they don't think they have the psychiatric problem, so they stop the medication by themselves. Then occlusal problems start again. It's okay.
Hello, sir. I have another question.
Yes.
So will all the malocclusion leads to TMD?
Sorry.
So she's asking, does all the malocclusion lead to TMD?
Malocclusion is malocclusion what? Malocclusion need TMD?
That is misaligned teeth.
Induce the TMD? The
Yeah,
question?
yeah. Can all the malocclusion cause TMD or some cause, some don't?
Yeah, good questions. Yeah, good questions. In 30 years ago, the UCLA researchers reported what's the name of this occlusion? Crossbite induced related with the TMD, but 30 years ago. Current researchers' idea is the malocclusion is not induced, does not induce the TMD. It's a current stream.
Okay, thank you, sir.
Thank you.
So I want to tell something to you, sir, that we Indians also believe that occlusion does not contribute to TMD. We don't think that we ask so many questions, so we believe that occlusion was responsible for causing TMD. We don't do any irreversible therapy, or we don't touch the occlusion of the patient if we think that occlusion is not, normally we don't do. So
Okay.
I think we are same
Good.
as the Japanese and American.
Good.
We are following the same. Don't think that we are asking so many questions, so we are doing occlusion reduction in patients with TMD. Okay.
Are there any more questions? I think there are no more questions now. So let's end the session for today. So this was the last lecture for the today's lecture series. Thank you so much, everyone, for your participation and cooperation. Thank you, the speakers, and the participants for making this lecture successful. And the theme for tomorrow's topic is management of orofacial pain, and we are hoping to see all of you tomorrow at 11 a.m. in the morning. Thank you.
Thank you, Sophia. Thank you, Machika Sensei. Thank you very much.
Shall we close for the day now?
Yes, please. Did you send the attendance?
Yes, attendance is already being recorded.
Thank you. Thank you very much, Dr. Nuru. Thank you very much.
Okay.
Thank you. Bye-bye. See you.
Bye.